Hello, thank you to Dr. Harris for a very kind introduction. He's our senior resident. So today we thought we'll have a CME on some topic which is little difficult, interstitial lung diseases, but nowadays more and more we are seeing this type of disease, and a lot of us have many questions in our mind. Even as a practicing pulmonologist, when I had started practice, I used to always get scared when an ILD patient would come in front of me, and I would start thinking, oh, now what test I have to do, what am I missing? So there are a lot of nuances to this topic, and hence I hope it will be very informative for all of you this afternoon, and thank you for coming down today. And we will proceed with the lamp lighting, and then we'll directly proceed with the sessions. Thank you so much. I would like to thank Apollo for giving us a live coverage as well, and we are covering these talks today on YouTube as well. It will be available for you to see later on. For the lamp lighting, I wish to invite Dr. Bhumika is already there, Dr. Suvadeep, Dr. Arjun, Dr. Atul Gattani, Dr. Akshay Chalani, Dr. Kapil. Please come forward for the lamp lighting.
Good afternoon, everyone. I am Dr. Dharmil Shah, first year DNB resident, and I am honored to be here today. It's a great privilege to me to introduce our first chairperson of the session, Dr. Akshay Chalani. Dr. Akshay Chalani is a consultant physician and intensivist, medical advisor, and lead critical care of Apollo Hospital, Navi, Mumbai. He is chairman of Mumbai Indian Society of Critical Care Medicine, executive committee member of West Zone Indian Society of Critical Care Medicine, and treasurer of ISCCM from year 2025 to 2027.
Yeah. So good afternoon, everyone. I will thank Pulmonology Department, Dr. Jay Lakshmi, and Dr. Bhumika, Dr. Arjun for giving me this opportunity, and welcome you all to the post-lunch meeting. I hope I will keep your lung volumes intact, and we'll start with the session. So the topic given to me is connective tissue disease related interstitial lung disease, focus on investigations and treatment. So coming to connective tissue disease. So connective tissue disease is basically an heterogeneous group of inflammatory disease, and it can involve joint, tendons, ligament, muscles, and also it involves specific organs. Systemic lupus erythematosus, rheumatoid arthritis, scleroderma are type of connective tissue diseases. The human lung is vulnerable for getting affected due to connective tissue disease because because of the abundance of collagen and blood vessel. So CTD-ILD is defined as interstitial lung disease demonstrated on CT in form of ground glass opacities, bronchiectasis, honeycombing, reticulation in the setting of established diagnosis of connective tissue disease. And interstitial lung disease is a significant cause of morbidity and mortality in people with systemic autoimmune inflammatory disease. Now coming to the pathogenesis, in the background of the genetic, background, whenever there is a trigger in form of like smoking, infection, GERD, there is an injury, epithelial injury, which triggers macrophage activation, and over a period of time there is infiltration of inflammatory cells, and over a period of time, if this continues, there is a chronic inflammation and we see the inflammatory lung injury. If this persists over a period of time, there is an activation of fibroblast, which lead into deposition of collagen, and there is decrease in the capillary beds, alveolar injury, and fibrosis. Now, CTD-related ILD is seen in almost all connective tissue diseases, out of which 3 common diseases, rheumatoid arthritis, scleroderma, and inflammatory myositis, usually have high prevalence of interstitial lung disease. So coming to the rheumatoid, so rheumatoid is a systemic inflammatory disease which affects small joints more than large joints, and all organ system can get involved. We know the risk factor for rheumatoid, and it is a common disease, and it is a leading cause of disability. And ILD is one of the many extra-articular manifestations of rheumatoid arthritis and leading cause of death and disability in patients with rheumatoid. ILD in RA has risk factors in common with rheumatoid, that is smoking, but there is an independent risk factor, like male patients with rheumatoid arthritis are more prone for interstitial lung disease. Now, as we all know, it presents with the symmetrical polyarthritis involving small joints. Sometimes it can present with mono or oligoarthritis and migratory symptoms, and it usually have systemic symptoms. Now, scleroderma is a heterogeneous autoimmune inflammatory disease which causes immune dysregulation, vasculopathy, and progressive fibrosis, and it involves multiple organs. The common organs which are involved in scleroderma are skin, GI tract, lung, and musculoskeletal system. Patient with scleroderma can be classified depending upon the skin involvement, either into limited or into diffuse cutaneous scleroderma. So the limited scleroderma patient have involvement of skin distal to the elbow and the knee, and involvement of face, whereas diffuse scleroderma has more diffuse involvement involving whole body. Interstitial lung disease is the leading cause of death in patients with scleroderma, and the progression of interstitial lung disease in patients with scleroderma is varied. So now, clinical features of scleroderma, as we all know, we see Raynaud's phenomena, sclerodactyly, and fingertip ulcers in patients with scleroderma. And the skin involvement depends upon whether it is a limited scleroderma, limited cutaneous, or diffuse. So we see involvement of skin. There can be calcinosis cutis, and early disease usually present with edema and puffy hands. Then arthritis, esophageal dysmotility, cardiac, renal and lung involvement are features of scleroderma. Idiopathic inflammatory myositis is a group of autoimmune disease which presents with muscle involvement, which presents with myositis specific antibodies and rash, and this patient commonly present with interstitial lung disease. The three forms of myositis which presents usually with interstitial lung disease is dermatomyositis, polymyositis and antisynthetase syndrome. The clinical feature of inflammatory myositis is proximal muscle weakness involving shoulder girdle and hip girdle, and in case of dermatomyositis basically there can be a skin involvement over face and chest, shoulder, thighs, and extensor surface of PIP and DIP in form of Gottran's papule. Then there can be features of mechanic's hand, which is basically a rash, cracking, fissuring of the skin of the palm and sole, and it is seen in antisynthetase syndrome. Now, other CTD. ILD also occurs in patients with other CTDs, including Sjogren's syndrome, which present with Sicca, xerostomia, and keratoconjunctivitis, and mixed connective tissue disorder. Interstitial lung disease is very common. Interstitial lung disease is rare in patients with systemic lupus erythematosus, whereas the other pulmonary vasculitis and pleuritis is more common in this patient. Now, coming to a case scenario, 55-year-old female presented with a palmoplantar rash associated with swelling of hands and pain. She was labeled as psoriatic arthritis and started on methotrexate. After more than 2 months, she developed breathing difficulty and dry cough. Evaluation, HRCT was suggestive of reticular opacity in lung, and serology, anti-SSA and anti-Jo was positive. So this is a patient of antisynthetase syndrome, which was mislabeled to be having psoriatic arthritis to start with, and there was a lapse in a diagnosis, and the period was there of 2 to 3 months where we could have catched and started treatment early. So how to evaluate these patients? Interstitial lung disease should be a differential diagnosis list for any suspected confirmed patients with CTD if there is following sign and symptom. 1. Unexplained breathlessness, then dry persistent cough, crackles on examination of chest, hypoxemia at rest or with activity, unexplained reduction in exercise capacity, and restriction on screening pulmonary function test. So, coming to diagnosis, the diagnosis of CTD-ILD is generally based on compatible clinical features. Only when there is compatible clinical features, this patient are evaluated. So, pulmonary function test, which suggests restrictive changes and gas transverse abnormality. Then HRCT showing reticular ground glass and consolidative changes. And also we have to exclude infection, drug-induced pulmonary toxicity and malignancy. There is a long list of drugs which can cause pulmonary toxicity, and many of the disease-modifying antirheumatic drugs can also cause drug toxicity. Many of the patients of CTD are on this drug, so we need to be careful while in making a diagnosis in this patient. The use of multidisciplinary team meeting, including pulmonologist, radiologist, and rheumatologist, is encouraged. So this slide shows how a multidisciplinary approach is important. So the primary care physician refers to pulmonologist and rheumatologist, which is the center of the team, and it involves other specialty also, including radiologist, physical therapist, occupational therapist, and a combined team approach is helpful for diagnosis and management of this patient. Now, lab test to order in the majority patient of CTD-ILD: CBC, LFT, creatinine, urine analysis, ANA by immunofluorescence. Usually we write ANA. So ANA is when you write a prescription for a test, you should write specifically ANA by immunofluorescence and not just ANA. And rheumatoid factor. Again we write RA. So RA is a wrong term for test. It is a rheumatoid factor. So Additional possible test for systemic rheumatic diseases. So if the patient is predominantly presenting with a symmetrical polyarthritis, then we order anti-CCP. If there is a proximal muscle involvement, then muscle enzyme and myositis associated antibodies, then anti-SCL70 and PMSCL. If there are Sicca symptoms, then we order anti-Rho and La. If there is a scleroductory predominant GRD symptoms, then anti-centromere and anti-SCL70. If there is mechanic hand, then anti-tRNA synthetase. And in patient with amyopathic dermatomyositis, where there is skin features of dermatomyositis, but there is no muscle symptoms, then MDA5. Coming to pulmonary function test, spirometry, lung volumes, diffusing capacity and pulse oximetry to assess the pattern, severity and progression. Reduction in vital capacity, lung volume, diffusion capacity for carbon monoxide, oxygen desaturation during exercise or on formal 6-minute walk test. And in rare diseases, there is resting hypoxemia. When assessing changes over time, clinically important difference include decrease in the forced vital capacity of more than 10% and change in DLCO of more than 15%. Restrictive abnormalities on PFDs are common even in the absence of symptoms and may reflect poor muscle strength or kyphosis. Poor muscle strength in patient with inflammatory myositis. This patient may show restrictive abnormalities on PFD or kyphosis due to osteoporosis. And so there will be discrepancy in reports. Measuring oximetry during exertion or 6-minute walk test provide more information regarding abnormal gas exchange than resting values. Coming to imaging, the most common HRCT patterns in patients with CTD-ILD are NSIP and UIP, and isolated organizing pneumonia patterns seen less frequently. In patients with rheumatoid arthritis, UIP pattern is more common, whereas NSIP and OP can be seen. The most common pattern in patients with scleroderma is NSIP. And in patients with ILD associated with inflammatory myositis, most common pattern is NSIP, but sometimes you can see NSIP and OP together. So 3 radiographic findings have been identified that suggest an ILD secondary to CTD. So the first figure, the first image shows anterior upper lobe sign. The arrow is marked where there is an involvement more anteriorly in the upper lobes. And second is extensive honeycombing. So more than 70% of the involved lung shows honeycombing in patients with CTD-related ILD. And then the straight edge sign, which is basically involvement of lower lobes and sparing of the lateral side of the lung. Now, all the patterns which are seen in idiopathic interstitial pneumonia can present in patient with RA-associated ILD. So the patients with RA-associated ILD can have chronic fibrosing interstitial pneumonia, which can present like UIP or NSIP, and smoking-related interstitial pneumonia can be there. So it can cause respiratory bronchiectasis and DIP, and acute and subacute IP presenting like OP or diffuse alveolar damage. So now this is the slide which shows what kind of involvement is present in different CTD. So rheumatoid arthritis and Sjogren's syndrome shows airway disease. Interstitial lung disease is seen in all the patients with, in all the CTDs. NSIP is more common in patients with scleroderma and polymyositis and dermatomyositis, whereas in patients with rheumatoid arthritis, UIP is more common. OP is more common in patients with inflammatory myositis, and involvement of pleuritis is more common in patients with SLE. Pulmonary hypertension is seen in patients with scleroderma and patients with MCTD. Just a minute. Now, invasive testing is advisable only in selected patients. So, if there is a suspicion that patient might be having or the symptoms might have worsened due to infection, then invasive testing is advisable. Then to rule out malignancy and to get a pathological information that would alter the management. So, bronchoalveolar lavage is usually advised to rule out infection. And lung biopsy is uncommon in current practice. As CTDs are systemic diseases, other systems can be involved that can affect respiratory symptoms on PFT and should be investigated. Pulmonary hypertension most commonly seen in patients with limited scleroderma and cause dyspnea, hypoxemia and decreased exercise tolerance. A reduction in DLCO out of proportion to the reduction in lung volume is seen in this patient. Then the muscle weakness most commonly associated with myositis spectrum of the disease can lead to dyspnea, reduced exercise tolerance and reduction in the lung volume. Muscle weakness can be evaluated by monitoring inspiratory pressure and expiratory pressure and looking at the maximal voluntary ventilation. Cardiac involvement in the form of obstructive coronary diseases and direct pericardial and myocardial involvement should be ruled out. And patient with scleroderma may present with other form of cardiac involvement. Monitoring. During the initial evaluation of patients with CTD-ILD, short-term PFTs within 3 months and HRCT within 6 months should be considered to clarify the rate of the progression. For the first 1 to 2 years, a mild CTD-ILD disease, PFT should be done every 6 months in this patient. More frequent, that is 3 to 6 months in moderate to severe disease. HRCT often performed yearly during the first 3 years to identify patients who are having progressive disease. An echocardiogram is often used every 1 to 2 years to assess pulmonary hypertension. Disease monitoring is more than cardiorespiratory monitoring for treating rheumatologists because disease activity can affect other organ system also. Now, coming to the approach, people with systemic autoimmune rheumatic disease who are at the increased risk of interstitial lung disease should be screened with pulmonary function test and high resolution CT. If the suspicion is high, PFT may not suffice because in early disease PFT can be normal. So HRCT is the best investigation to rule out interstitial lung disease in CTD. If ILD is not diagnosed and there is a high index of suspicion, this patient should be followed up appropriately. And if ILD is diagnosed, then the serial monitoring is advisable. Now coming to the case scenario, 35-year-old male presented with breathing difficulty, HRCT, NSIP plus OP, rheumatoid factor anti-CCP positive, no inflammatory arthritis to start with. After 2 years, patient developed severe inflammatory arthritis. Second patient, 45-year-old female, Sika symptoms with breathing difficulty, ANA by IF strong homogeneous with anti-Rho positive, breathing difficulty, HRCT and PFT normal, electrolyte abnormality, patient is having Sjogren's with renal tubular acidosis. Then 50-year-old male non-smoker presented with breathing difficulty, HRCT suggestive of NSIP, ANA 1:1000, immunoblot negative, no other features suggestive of CTD. And there is one more, I think it is not visible. So, okay, fine. So we'll come to next slide, which is basically when there is an interstitial pneumonia with autoimmune feature. So what it means is presence of interstitial pneumonia by HRCT and exclusion of alternative etiologies and does not meet criteria to get diagnosed as connective tissue disease. There is no clear-cut diagnosis of connective tissue disease. In this patient, at least one feature from 2 of the domains are needed. First, clinical domain, second, serological, and third, morphological. So, in clinical domain, so there can be just subtle signs like distal digital fissuring, that is mechanic's hand, distal digital tip ulceration, inflammatory arthritis or polyarticular morning stiffness, of more than 60 minutes, palmar telangiectasia, Raynaud's phenomena, unexplained digital edema, unexplained fixed rash on the digital extensor surface. Serological domain. So these are the multiple autoantibodies. If some of it is positive, then it can be considered. And morphological domain, usually the changes in HRCT. So now coming to the treatment. So all treatment decisions should be made in close collaboration with the rheumatologist, as there are medications that can treat both interstitial lung disease as well as CTD, and effort should be made to minimize the medication and choose an effective medication for both disease. In general, medication therapy involves either immunosuppressive and or antifibrotic therapy and depends on the type of ILD, whether it is NSAID, OP or UIP. An important concept to remember is that the control of connective tissue disease doesn't mean that the interstitial lung disease is controlled. If the connective tissue disease activity is under control, still there can be active interstitial lung disease. And outside scleroderma ILD treatment, CTD ILD is severely hindered due to lack of the evidence. So coming to RA-ILD, treatment regimens are limited to case reports and case series without dedicated phase 3 trial. The only Food and Drug Administration approved therapy is nintedanib, which is approved for progressive fibrotic ILD irrespective of etiology. There are limited reports of successful treatment with azathioprine, cyclosporine, mycophenolate, and rituximab. We usually don't advise methotrexate and TNF-alpha in these patients, though there are case reports. Scleroderma ILD, traditional immunosuppressive therapy with mycophenolate, cyclophosphamide have been used in initial treatment of scleroderma ILD. MMF is a drug of choice because of its superior side effect profile. Azathioprine is an option, but the results are mixed. The use of systemic steroid in treatment of scleroderma is discouraged and debated. Data on use of high-dose steroid in scleroderma is very limited, and steroid need to be, there is a risk of scleroderma renal crisis. So steroid is usually avoided in patients with scleroderma. Inflammatory myositis. So there are no large randomized controlled trial in this patient, and almost all the immunosuppressive drug do show improvement in this in ILD related to inflammatory myositis. And other CTD, MCTD, Sjogren, ILD respond to immunosuppressive drug better than patients with scleroderma and rheumatoid arthritis. And there should be a screening and treatment of antiphospholipid syndrome, antiphospholipid antibody whenever necessary. Coming to nintedanib. Nintedanib is a tyrosine kinase inhibitor and shows effective in interstitial pulmonary fibrosis. Has been approved based on result of inbuilt trial for all patients with progressive fibrosing ILD. And it is also approved in fibrosing ILD in patient in CTD ILD. And with one of the following criteria in prior 24 months. A relative decline in FVC of more than 10% of predicted value, a relative decline of FVC 5 to 10%, and worsening of, in respiratory symptoms, or is increase in the extent of fibrosis in HRCT, and worsening in respiratory symptom and increase in extent of fibrosis in HRCT. So now coming to the flow chart. So first line therapy for patient in all of the patient of CTD and ILD is basically mycophenolate. So then mycophenolate in patient with systemic sclerosis, tocilizumab is used and rituximab again is used in all patients with CTD. So the additional option for treatment are cyclophosphamide and azathioprine. Sometimes JAK inhibitors can also be used, and calcineurin inhibitors can also be used. There is a strong recommendation against use of glucocorticoids in patients with scleroderma, whereas short-term glucocorticoids can be used in other connective tissue diseases. Now, if there is a progression after starting the first line therapy, there can be a switch. For example, a patient with scleroderma, if we have started the patient on mycophenolate and the patient is not responding, then we can change it to tocilizumab. And long-term glucocorticoids are discouraged. If there is a rapidly progressive interstitial lung disease and there is an MDA5 which is positive, then IV glucocorticoids are indicated. The additional option which can be added is rituximab cyclophosphamide, and this patient can be considered for early lung transplant. So again, just few slides. 45-year-old female presented with history of breathing difficulty since 1 month and dry cough. HRCT suggestive of interstitial lung disease with NSAIP. Patient was referred from pulmonary department. ANA is strong positive with RNP positive. Then there is a further history of proximal muscle weakness. Patient was started on steroid and MMF. After few months, patient developed inflammatory arthritis and patient was started on methotrexate, and there is regular monitoring. So there are reports that methotrexate cannot be used in patient with ILD, but sometimes you have to use in a specific scenario, and it's not that methotrexate usually cause the lung damage. Adjunctive therapy, oxygen therapy, GERD management is very much necessary in patient with scleroderma with long-term PPIs. Pulmonary rehabilitation, vaccination is very much necessary, and supportive care. Then lung transplant. Transplant should be considered in all patients with disease that progress despite of therapy. The outcome of transplant of CTD-ILD are similar to other forms of ILD. Certain features of CTD can affect patient likelihood for qualifying for transplant. Then in patients with scleroderma, usually lung transplant is difficult because of history of GERD, but it is not a contraindication. And in very few patients, hematopoietic stem cell transplant can be used. So take home message, CTD-ILD is a major cause of morbidity and mortality in patients with systemic autoimmune disease. Early recognition is very much critical because as early as we recognize the damage to the lung and morbidity and mortality is decreased, treatment must be individualized depending upon the type of CTD and type of ILD. Immunosuppressive agent can be used. Long-term corticosteroids are discouraged, specifically in patients with systemic sclerosis. Multidisciplinary approach is very much necessary, and this patient should be very closely monitored. Thank you. Yeah.
Is there anything we can do? Suppose you are following rheumatoid arthritis patient at one point of time, we can do something to prevent the occurrence of ILD. Can we do something so that the occurrence of ILD in the rheumatic arthritis patient or scleroderma patient is delayed or prevented?
No, basically disease activity and relation of ILD I have said means if there is an other parameters like a patient with rheumatoid arthritis doesn't have any joint activity so the disease activity is controlled as per rheumatoid arthritis, but still an ILD can progress. So
whether as an OPD basis when we see the patient, whether we can do something so that the onset of ILD is delayed?
No, basically what we have to do whenever we have a high index of suspicion, like patient is on treatment, patient is on treatment, the disease activity is controlled of rheumatoid arthritis. And then if there is a high index of suspicion, we have to do regular monitoring, that's all.
So I would now like to call Dr. Meera Hingrani ma'am for giving a token of appreciation to Dr. Akshay Chanani sir and Dr. Atul Gatani sir as well. So now we move on to the second session for today, which focuses on idiopathic pulmonary fibrosis by Dr. Jayalakshmi ma'am. So I would like to welcome Dr. Vaishali Lokande ma'am, who is the chairperson for this particular session. Dr. Vaishali Lokande ma'am, she is a consultant physician in Apollo hospitals. She is a DNB faculty examiner, FCFS medicine examiner, and examiner in MBBS and BDS examination as well. So she is a speaker at various MMC accredited CME, speaker at state and national conferences as well. So her areas of interest are diabetes and geriatrics. She is a treasurer at Maharashtra Association of Physicians as well. So I would like to, Vaishali Lokande ma'am will now introduce the speaker, Dr. Jayalakshmi ma'am.
Thank you. So yeah, it's great a pleasure to introduce our next speaker, Dr. Jayalakshmi. I'm sure every one of you know her, but for a recap, she's a professor here, and she's not just a professor by years of experience, but a professor with multiple publications to her credit. She is a KM and NIR alumni, and of course has also a degree of European Respiratory Improvement in Respiratory Medicine 2013. She has been trained in EBUS and thoracoscopy from Singapore and also from Italy. She was COVID task force member with the Apollo Group Pan India since March 2020. She has an award for credit Arogya Tarasamana Award in 2021 for her service towards COVID patients. She was under MRCP in December 2022. She is not just all this, but also a yoga teacher course she's done from Yoga Vidya Niketan. She has done a course in sleep medicine, and her motto is keep learning, teaching, growing, stay young, and strive for excellence. She will take us to the maze of idiopathic pulmonary fibrosis. How do you untangle the whole thing?
Thank you so much, Dr. Vaishali, for a very kind and generous introduction. So today we will go on to the talk on idiopathic pulmonary fibrosis. So basically the whole gamut of interstitial lung disease is diseases which involve the lung interstitium. Dr. Gattani just touched upon the ones which involve through the method of connective tissue diseases. So the pulmonary fibrosis can occur in many interstitial lung disease, and it causes a fibrotic changes in the lung, describing an almost always irreversible structural alteration. So this is a large group of diseases and relatively less common. Nowadays we are seeing much more and more of these interstitial lung diseases, probably because of the increasing pollution, aging population, increasing hypersensitivity pneumonitis, increase in the connective tissue disorders. And we usually can get a diagnosis with the HRCT in addition to the history, examination and findings. So what is the hallmark of this idiopathic pulmonary fibrosis or lung fibrosis? The hallmark is fibrosis. So the earlier times, like decades ago, it was initially thought of as an inflammatory disease predominantly. So that is why the role of treatment was more for steroids, immunosuppressive drugs. So I remember we used to treat IPF with azathioprine, steroids and acetylcysteine. This was the trio of medications which we used to use treat IPF. But slowly the understanding of the pathophysiology improved, and now we know that it's not so much as an inflammatory disorder as more of a fibrotic disorder, and hence the spectrum of treatment started changing to include the anti-fibrotic medication. So it is basically formation of a scar tissue, and because of a tissue damage or some inflammatory process, and there is a specific cellular process in which activated fibroblasts or myofibroblasts produce excessive extracellular matrix. So pulmonary fibrosis, many patients come and say lung fibrosis ho gaya. So lung fibrosis is not really interstitial lung disease. Interstitial lung disease can be whole spectrum of diseases. Like Dr. Gattani said, can be connective tissue, can be because of drug, it can be because of an infection, can be because of just a viral infection. So all can be interstitial, but in that pulmonary fibrosis is a small group. In that idiopathic pulmonary fibrosis is a small group. Still, although it's a small group, it is one of the most common forms of lung fibrosis which is seen, hence it is very important. Some ILDs may not be fibrotic. So in NSIP, in hypersensitivity pneumonitis, initially there may not be fibrotic changes. So also presence of fibrosis does not mean it is progressive. Many people Google, patients when they come to us, they Google lung fibrosis. Or if we tell them they have a fibrotic lung disease, they will Google and come and say कि अभी हो गया, अभी हमको सिर्फ 3 साल जिंदा रहने को है, अभी आप बोलो हमको क्या करने का, हमने Google में सब पढ़ लिया. So what they are reading in Google is actually the idiopathic pulmonary fibrosis with the 3 to 5 years of lifespan and requirement later on for oxygen, lung transplant, all these things. But any fibrotic lung disease, even TB can cause lung fibrosis. Even any type of infection can cause a small fibrotic lesion in the lung. That is not equivalent of pulmonary fibrosis as we understand it when we talk about a pulmonary fibrosis. So just in brief, the interstitial lung disease can be divided into idiopathic interstitial pneumonias, autoimmune ILDs, which already has been spoken about, hypersensitivity pneumonitis, we'll have a talk about it soon, sarcoidosis and other interstitial lung disease, the rarer ones like the LAM, Langerhans cell histiocytosis, drug-induced, other forms, vasculitis. So these are more rare, they may be associated with cyst and they may have a very different type of presentation. In the idiopathic interstitial pneumonias, we can have IPF, the NSIP presentation, respiratory bronchiolitis, interstitial lung disease, RBILD we call it. Usually it is associated with smoking, responds well to steroid. Then we have a desquamative pneumonias, cryptogenic organizing pneumonia which presents as interstitial lung disease but with patchy organizing pneumonia type of picture, or an acute interstitial pneumonia which can present in a very acute widespread form, may mimic like a viral pneumonias as well. So how do we diagnose it? Main first thing is history for all of us to know. Usually the history will be dry cough, only cough and gradually increasing breathlessness on exertion. So this is the usual commonest history. Since it is slow in onset and it is gradually progressing, it is often missed in the earlier stages, and many times when the IPF patient comes to you, patient already has an extensive lung disease when you check the lung function test as well as the CT scan. So then further you go on to do a chest x-ray and a spirometry. That's why in every patient whom we are having breathlessness and we are suspecting asthma, we always need to get a baseline x-ray done, because many times you will miss an fibrosing lung disease if you have only done a lung function test and seen some reversibility and you are giving inhalers. You might miss a interstitial lung disease, which happens more often than we like it. And we do the test, further tests like blood test. Mostly the blood tests are to see the hemoglobin, see the general liver, kidney function, as well as to rule out the autoimmune causes as explained by Dr. Gattani. And then you do go after the CT scan, if possible you go for a histopathological biopsy, or directly you go for a multidisciplinary meeting. We'll just talk about that. So basically you do lung function test, we don't do only a spirometry. We usually do a diffusion capacity which is more sensitive, which can check more sensitively as to whether the gas exchange of the lung is good enough. So the DLCO is what we look at, which is a more sensitive parameter than only a lung function. Many times a PFT test, which we normally do, is maybe normal in many of the earlier cases. Also we do a 6-minute walk test. In 6-minute walk test, you are basically seeing whether the patient is getting any desaturation. So normally what happens when we walk, if our saturation is about 98, it may go up to 99. But if a patient with interstitial lung disease, they walk because of the increased oxygen requirement, but the lung, because of the thickness in the lung, is not, thickness of the diffusing membrane, is not able to give more oxygen, and hence the saturation actually falls. So when they walk, they have a fall in saturation. So this is what is checked in the 6-minute walk test. Also we check the distance to which the patient can walk. And so we do the DLCO and we check the diffusion capacity 6-minute walk test and arterial blood gas. So you check the oxygen saturation as well as try and check the arterial blood gas if possible. Why the arterial blood gas helps us? Because through a broad range of PO2, the saturation will still remain above 90. So you may have a patient with a PO2, partial pressure of oxygen, only 60, but the saturation will still be above 90. So really if you want to come to know how bad the oxygenation is, you need to do a blood gas. It also helps us to see whether there is any washout of the carbon dioxide, which is usually the case in these patients, or whether the carbon dioxide level is increased, which shows a much more advanced disease. Usually the pH, the carbon dioxide will either be normal or reduced in these patients, and only the oxygen will be reduced. So HRCT is the gold standard. Like CT scan really revolutionized the diagnosis of interstitial lung disease. It was one of the main things with which we could really differentiate. Otherwise, with only the X-ray, TB, ILD all looked the same. Lung fibrosis. So here you can differentiate between different patterns. So in idiopathic pulmonary fibrosis, mainly we see a pattern called as a usual interstitial pneumonia. So UIP pattern is seen. So what are the hallmarks of usual so also the criteria for the lung progression is so another thing when we are doing examination is we have to see how fast the person is progressing. This is very important in order to step up the treatment, whether patient is going to require oxygen, whether patient requires admission, also whether patient needs to be referred for lung transplantation. So how do we do that? We see the symptoms, we see whether exacerbations is there, we see the CT scan. So CT scans are repeated every year in these patients. We see the lung function test. Typically lung function tests are repeated at least every year. If not, we should repeat at least every 6 months to see for the progress in these patients and to see how much there is a decline in the lung function test in spite of the medications. As we will see later, even the medications don't really reverse this disease. Usually they only cause a decline in the speed of progression. There is something called as a gap index where we see the gender, the age and 2 physiological parameters like FVC and DLCO, with which we can make a gap score so that we can have an idea about the severity of the disease. So coming to idiopathic pulmonary fibrosis, it is a specific form of progressive ILD and there is a specific radiological pattern which is the UIP. And what is there in UIP? You have bibasilar reticular abnormalities as we are seeing in this image. We have traction bronchiectasis and we have honeycombing. So all three are seen in this picture. So in the basal part we are seeing the honeycombing and we are also seeing the traction bronchiectasis. That is the bronchi are thickened and they are widened. And there is a subpleural predominance to this whole thing and there are areas of relative sparing. So this is the typical UIP pattern which is seen in the idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is the most common of the idiopathic interstitial pneumonias. 3 to 9 cases per lakh population has been estimated. Many of the cases occur in patients with history of smoking. Tends to present in the 6th or 7th decade of life, but we are also seeing much more earlier presentations and it is more common in men. What are the risk factors? Older age, male gender. There are some genetic factors which are being studied. So there are various studies regarding the telomeres. Studies are there, tolnip mutations are there, specific mutations are there in the genes which predispose to the development of idiopathic pulmonary fibrosis. There are specific mutations which also confer a good treatment benefit or a survival benefit to these patients. So these are much more being studied in detail. Eventually we'll come to the era where we have genetic testing and we have specific treatments individualized treatment based on these specific genetic testing. Also, we need to look into gastroesophageal reflux because gastroesophageal reflux increases the severity of the interstitial lung disease and also has been told to be one of the causating factors for the IPF. And what are the clinical manifestations? So as we discussed, breathlessness, dyspnea, coughing, dry cough usually, finger clubbing may be there, fatigue may be there, aching joints, weight loss, and on auscultation we get the typical velcro crepitations or the typical inspiratory crepitations in the basal region which keeps on going up, increasing as the patient gets more advanced diseases. Usually we don't get wheezing in these patients or rhonchi, these are not found, it is usually crepitations. What are the clinical course? There is a gradually progressive course in this illness and usually over 3 to 5 years is supposed to be the lifespan. Some people deteriorate much more faster than the others and this deterioration we will be able to judge by looking at the CT scan and by looking at the lung function test. One of the dangerous things in IPF is the acute exacerbations. We have heard of exacerbations in COPD. Even the IPF patients do have exacerbations, and many of them are not linked to infections. They would just have a sudden increase in the breathlessness. We'll need to have to admit them, give them more oxygen. Sometimes they require ICU admissions. And it is always a very scary part. If they improve fast, it's good. But if they remain and then they get infected, so the mortality rate becomes very high because already their lungs are so much compromised that any acute exacerbation, we see a mortality of 40 to 50% in these patients when they get an acute exacerbation. As we know, IPF patients or patients with severe lung disease, it's very difficult to intubate them and then get them out of the ventilator, because once they're intubated, the chances for getting them out of the ventilator become even more difficult. Chances of infection are also higher because of their poor immunity and long-standing lung disease. So these exacerbations are there, can occur in many patients. So in yearly 16% can get exacerbations. Median survival after an acute IPF has been shown to be 3 to 4 months only in some patients, and also they more than 50% can die after being hospitalized with an exacerbation. So we need to exclude other ILDs. We need to identify the UIP pattern on the CT scan. We need to confirm the UIP by surgical lung biopsy if it is required, if UIP is not present by HRCT. And we need to talk about the surgical lung biopsy, which percentage of the patients will go for that. So now there is an option also of doing a cryobiopsy of the lung. The usual transbronchial lung biopsy tissues used to be very small, and hence that has practically been given up for the diagnosis of IPF as such. It can be used to rule out, like if the patient is suspected to have sarcoidosis or other diseases, then patient may be subjected to a transbronchial lung biopsy. So this is the algorithm. You see the patient potential, see the CT scan. If there's a specific diagnosis, okay, then you go to the multidisciplinary discussion. And if there's no specific diagnosis clear, then you either opt for the surgical lung biopsy or the bronchoalveolar lavage. Again, go for the multidisciplinary discussion, and then come to a conclusion that this is IPF or this is not IPF. So in 2022, the ATS came out with guidelines which said that, so the updated guidelines was that you can also use a transbronchial cryobiopsy, which gives a better yield and a better tissue instead of a surgical lung biopsy. Also, it said that if there is a gastroesophageal reflux disease, you don't have to upfront go for a surgical treatment of that in order to give a better outcome for the IPF. It was not proved that it will give a benefit. And also, the discussion was made about this particular term, progressive pulmonary fibrosis, or PPF. So till now we have been talking about idiopathic pulmonary fibrosis. Now PPF is a term which is given for interstitial lung disease, not IPF, but which are progressing in a similar way as IPF. So they are a progressive fibrotic disease, but the cause is not an idiopathic pulmonary fibrosis. Cause can be hypersensitivity pneumonitis or other connective tissue disease, lung disease, but also they are progressing, and hence they are called as a PPF. Now in PPF as well, you can use nintedanib, one of the drugs which was being used for idiopathic pulmonary fibrosis. We'll come to the drugs in a little while. And so we can also go for that. And also pirfenidone also was studied in this subgroup of patients. So there was a new subgroup which was defined. What is a progressive pulmonary fibrosis? So this is about the CT scan pattern. So there is typical CT scan, typical UIP, probable UIP, CT pattern indeterminate and not conclusive. So these are the 4 classifications for the IPF. To determine whether there is an UIP or not. Basically, you see those 3 things, whether they are present or not. That is subpleural fibrosis, traction bronchiectasis, honeycombing, whether they are present or not present. And then you can correlate it with the CT scan, whether the CT scan is also showing typical UIP, probable UIP, indeterminate, or whether it is showing an alternative diagnosis, that is the histopathology. So you have the CT scan on one side, and if you have a biopsy, you have the histopathology on the other side. And what about bronchoalveolar lavage? If there is a typical presentation on the histopathology on the CT scan, you don't really have to go for the bronchoalveolar lavage. But if there is no typical diagnostic presentation, then you can go for the bronchoalveolar lavage, do a cellular analysis, and see whether it supports your diagnosis or whether it is giving an alternative diagnosis. So these are the these are the specific tests showing the epithelial cell dysfunction, immune dysregulation, so the TOLIP cells, the MUCB mutation. So these are the mutation studies which have been recommended as part of the 2022, but there has been no recommendation for or against addition of a genomic classifier testing. Insufficient agreement as on the 2022. Probably the next update will be more specific about which test to do and in whom to do these tests. So the multidisciplinary team, what will it have? The primary care physician, the pulmonologist, the rheumatologist, the radiologist and the pathologist. This will be part of the MDT to come to the conclusion as to whether this is IPF treated as such or it is some other type of interstitial lung disease. So this is the algorithm. You have cough, you do the CT scan, you do the lung function test, do the bronchoscopy if required or a biopsy, decide on whether you want to do a transbronchial or an open lung biopsy and come to the diagnosis. So now we'll come, moving on, we'll come to the management. Now the management of idiopathic pulmonary fibrosis has practically revolutionized over the last 10 years. So earlier, as I said, it was thought to be an immune suppressive, immunological disease, and immune suppressive medications were used, steroids, azathioprine, mycophenolate. So these were the drugs which were used for the treatment. But as we understood that it is more of a fibrotic disease, and antifibrotics started coming up. So two drugs were studied. First pirfenidone was studied, and then nintedanib came up. So we'll just see how it came up. And then there are the other medications like sildenafil for the additional pulmonary hypertension, statins, role of N-acetylcysteine, role of steroids. So it started like that. 2010, pirfenidone was approved for IPF. Then there were these trials published, the Capacity trial, Tomorrow trial, Ascent trial. Impulses 1 and 2 was studied, nintedanib. And then DCG approval for nintedanib for IPF. Initially, for the first few years, we used to have discussion whether we can give nintedanib or not. Nintedanib was very much more expensive compared to pirfenidone. Slowly now, the rates have come down and the two drugs cost almost equal amount. Then the inbuilt trial was studied where nintedanib was looked at the other pulmonary fibrosis patients as well. So the other pulmonary fibrosis which did not fit into the idiopathic pulmonary fibrosis. It was also found to have a good benefit, and hence US FDA has approved nintedanib for progressive pulmonary fibrosis, PF-ILD it's called, for scleroderma, interstitial lung disease, and it's being approved for more and more indications as more and more studies are coming in. So this was the timeline. Initially corticosteroids, azathioprine, colchicine, NAC, interferon gamma antagonist, etanercept, imatinib, bosentan, pirfenidone, nintedanib. Then now statins, sirolimus group of medications are now in the picture for the management of IPF. Very briefly, I will tell you about nintedanib and pirfenidone, which are the two main drugs which are being used for the treatment of IPF. So it's a small molecule tyrosine kinase inhibitor. It binds to the ATP binding sites of PDGF, VEGF receptors, basically vascular endothelial growth factor receptors, and it blocks the intracellular signaling cascades involved in proliferation, migration and differentiation of lung fibroblast and myofibroblast, which are the hallmark cells in the fibrotic lung diseases. It also has anti-angiogenic and anti-inflammatory activity. So this is the mode. And coming to the action of pirfenidone, it is an antifibrotic. It works for fibrogenic growth factors, fibroblast proliferation, and it's also anti-inflammatory, and it also has an antioxidant role. It is not clear which of these effects occur at what doses. Mechanism of action is not very clear, but it is yet shown to be of benefit in the interstitial lung disease. So in this Impulses trial, where nintedanib was studied, 150 mg dose twice a day, there was an annual rate of decline in forced vital capacity. So what was seen was that how much is the annual rate of decline and how much does it improve as compared to placebo with the nintedanib medication. So it was found that the annual rate of decline was 113 or 109 ml per year adjusted as compared to the placebo, which was 223. So there was a huge difference, almost twice the amount of annual rate of FVC decline was seen in the placebo patients as compared with the nintedanib group, and hence this drug came to be approved for the treatment of IPF. So here point to be noted is that there is no reversal in the lung volume. There is only a decline in the rate of progression. But this also helps a lot because it improves the duration of longevity of these patients, and also these drugs have been shown to reduce the time to the first exacerbation. So as we saw, the exacerbations were one of the main things which were leading to death in these patients, and this drug was also helping in that. So pirfenidone, nintedanib and acetylcysteine treatment, so this was another review which was done, and pirfenidone and nintedanib were shown to have a clear treatment risk difference even in reducing the acute exacerbations in these patients. So these were the studies which actually defined our treatment, what we are giving now for the interstitial lung disease patients. A few other drugs which have been tried. Thalidomide has been tried. We know from history that thalidomide has a lot of side effects, congenital defects and all, so it was gone out of contention actually. But now it is again being tried for the treatment of idiopathic pulmonary fibrosis, not yet being used in mainstream. Gastroesophageal reflux therapy is very important in this group. It needs to be evaluated, and if gastroesophageal reflux is there, it needs to be treated. A blanket treatment of gastroesophageal reflux medications for all patients is not indicated. Non-pharmacological therapy, lung transplantation, supplemental oxygen, pulmonary rehabilitation, these are actually the cornerstone, because the only real life benefit which is being shown for these patients is with oxygen therapy, rehabilitation and transplantation. We have Dr. Kapil here who will be talking more about the indications for transplantation and about lung transplantation in the advanced end-stage ILDs. So I will not go more in detail about it. But supplemental oxygenation is very important in hypoxemic patients with a saturation of less than 88% or PaO2 of 55 at rest or even during exercise. So they can be given supplemental oxygen. It improves exercise performance as well as it reduces the chance for them to develop the pulmonary hypertension. I'll not talk about the lung transplantation. We spoke about this new entity which is the progressive fibrosing ILD or the PF-ILD. Just to say what is the definition. So when there is a decline in the FVC more than 5% predicted within 1 year of follow-up, or there is an absolute decline in the DLC of more than 10% predicted within 1 year of follow-up, or there is a radiological evidence of disease progression, increase in the extent of the disease, new ground glass opacities, new reticulations, new honeycombing, and worsening respiratory symptoms, these patients can be called as a progressive pulmonary fibrosis. So this is a particular subgroup which can benefit from the antifibrotic medications, which was studied further in the inbuilt trial where they studied 663 patients with fibrosing ILDs other than IPF. And they found that even in these patients with the medications, they had a significant reduction in the decline of the FVC. So in these 663 patients, we found that the rate of decline of FVC was 82 with nintedanib and 211 with placebo. And most of the patients in this group were fibrotic hypersensitivity pneumonitis. So this is just a general overview. So we can have ILD with scleroderma, RA, sarcoidosis, chronic HP, idiopathic NSIP, unclassifiable ILDs, and all of them, they can be treated with steroids, immunomodulatory medications, but when they are progressive fibrotic stage, then they can be treated with nintedanib. And IPF, main management is with antifibrotic drugs like nintedanib, pirfenidone, lesser role for steroids and immunosuppressive medications. So these are the guidelines comparatively from 2015 to 2022. So anticoagulation was earlier recommended, which is not anymore recommended for use. Imatinib is not recommended. Azathioprine and acetylcysteine not recommended. Ambrisentan is not recommended for use of PAH in IPF because of increase in hemorrhagic possibilities. The only drug which was recommended, if at all pulmonary hypertension is present, is sildenafil, which can be used. Antacid medication only if the patient has GERD symptoms and not as a blanket. Double lung transplantation and not single lung transplantation. No recommendation for treatment of pulmonary hypertension. And nintedanib and pirfenidone both have been suggested for use in the idiopathic pulmonary fibrosis. So thanking you a lot for very patient hearing. And
Any questions from your audience? I have a question to you, Dr. Jana. Actually, this is like a life, it's like a death sentence, I feel, once you've been given a 5 year. And how much is the number of... Yeah, sorry. So it's like a death sentence, I feel, once you've been given as an IVF or PVF. How much like is the additional number of years or lifespan improvement with these drugs? That's question number one. And once you start these medications, I believe they are for life, right?
so once you start these medications, they are for life. So as we saw, because of the increase in the incremental or less decline in the FVC, they get a further lease of life because they are able to maintain their lung volumes for a more period of time. So there have been patients who have been on these drugs for up to 10 years, whereas earlier the survival would be 3 to 5 years without these medications. So these have been a game changer for these patients with this group of disease. It is lifelong, but generally these drugs are well tolerated. The side effects, like for nintedanib, is more of liver dysfunction and gastro-related, like loose motions are the most, diarrhea is the most one. Usually it gets corrected by adjusting the drug dosages, stopping the drug for some time and restarting. If there is a severe liver function alteration, then we cannot use the drug. With perfenidone, also it's usually well tolerated. Gastric GI side effects are more. Some of the patients get a photosensitivity or a rash, but usually they are well tolerated.
What's the monthly cost of therapy?
Around 4,000 to 5,000 per month. It's not that, yeah.
And do we have total oxygen concentrators the patient can carry?
Yeah. Yeah.
Because those who are ready only will require...
We have. So nowadays the oxygen concentrators come in 1.5 to 2 kg. Usually they can carry it on their bag if they carry it in a backpack, or they usually have a stroller which becomes easier for them. Many patients come to the OPD carrying that nowadays. Cost of that has also gone down from 2.2 lakhs to around 1.5 lakhs, some of the manufacturers. So the life is changing for them.
If they are compliant and they can afford the concentrator, I think they can still be productive lives with some...
Yes, many of them, if they have office work or work from home, they manage to do it. The only scary part is when the oxygen requirement is much high and they're going into pulmonary hypertension, or the fear of getting the acute exacerbations. And lung transplantation is also proving to be a major game changer in these patients. So we will come to that later.
Very nice.
Thank you.
Thank you.
Thank you.
Thank you, ma'am, for the very insightful session. I would like to call Dr. Harish Johanna, sir, for giving the token of appreciation to Dr. Jayalakshmi, ma'am, and Dr. Vaishali, ma'am. So our next session is on hypersensitivity pneumonitis by Dr. Bhumika Madhav. I would like to call Dr. Prachi Sankhe, chairperson of our next session. Dr. Prachi is a consultant physician, internal medicine specialist at Apollo Hospital. She is an associate professor at D.Y. Patil Hospital with over 10 years of experience. She specializes in a wide range of medical conditions. Dr. Prachi will introduce our next panelist, Dr. Bhumika.
Good afternoon, everyone. I would like to invite my friend and your colleague, Dr. Bhumika Madhav. She is a consultant pulmonologist at Apollo Hospital, Navi, Mumbai. She has pursued a diploma in pediatric sleep medicine, certified course in allergy and
Thank you so much for the kind introduction. Thank you, Jayalakshmi ma'am, for giving me an opportunity to talk today. So, when I was a resident, interstitial lung disease was extremely confusing for us. We just could not understand. Hypersensitivity being a part of ILD was also extremely confusing. So in this session, I'm going to be discussing a little bit about introduction, the risk factors associated with it, a little bit about pathophysiology, investigations, treatment, and I'll also be discussing a few cases. So what is hypersensitivity pneumonitis? So hypersensitivity is basically excessive immune reaction, pneumonitis being inflammation in the lungs. Hypersensitivity pneumonitis is a complex interstitial lung disease which is caused due to exposure to inhaled antigen. It is a type 3, type 4 hypersensitivity reaction. And it occurs to those patients who have developed an exaggerated immune response following an inhalation to an inciting antigen or a mixture of antigens. So this is the old classification of hypersensitivity pneumonitis. Initially, we used to divide those patients with acute, subacute and chronic HP based on the time duration to which the symptoms they had. And the newer classification is non-fibrotic hypersensitivity pneumonitis and fibrotic hypersensitivity pneumonitis. So this is, the first case is actually one of our colleagues. When we had just joined our post-graduation course in the first year, within a few months, one of our medicine colleague started complaining of cough since last 10 to 15 days. He had desaturation, he had fever, he had flu-like illness. So we initially thought it was some viral infection or maybe he was developing asthma. His oxygen level was around 88-90% at that time. Auscultation, there were bilateral breath sounds which are present and there were a lot of squeaks which were there. This is a chest X-ray. The chest X-ray shows a little bit of patchy opacities. And this was the CT scan that he presented with. So the CT scan here shows a mosaic attenuation. There is a little bit of small airway disease component also which is seen. So when he showed one of our first year co-colleagues, the friend of mine started him on asthma treatment, but there was no symptom relief at all. On taking a detailed examination and taking a detailed history, he told us that about a month ago they installed an AC, and on that AC there was one pigeon nest which was there, and there was some foul smell every time they used to turn the AC on. So the diagnosis of acute hypersensitivity pneumonitis was made and he was started on oral steroids. So initially when the diagnosis of hypersensitivity pneumonitis was made, I was really nervous because most of the patients that we saw at that time were all chronic HP, they required oxygen, they used to keep getting admitted with exacerbations. But when he was started on oral steroids, he made a miraculous recovery. Within a few months, he was absolutely normal. In fact, now he's in States right now. He gave his exam and everything, and he's well settled in States. So the learning point from this case is that we need to take a detailed history, and so that we can take a timely, so that when we get a timely diagnosis, we can start the treatment accordingly. So the second case is a 70-year-old female. She presented with acute history of breathlessness. She also had a history of asthma in the past, and chest X-ray had showed some lows on opacities. So she had been lost to follow-up after that. So both her and her mother had similar symptoms. The mother had more serious symptoms as the daughter had more serious symptoms as compared to the daughter. She required oxygen and she had very severe symptoms. The mother was comparatively better. They had a pigeon exposure. That whenever they used to sit in the balcony and whenever the AC was turned on, there used to be a foul smell which used to come. Pigeon feathers, excreta, humidity in the AC vents, air coolers, molds, all of these can lead to hypersensitivity pneumonitis. So the daughter, who was more serious, was started with oxygen, steroid therapy. Within 6 months, she had recovered. But this lady, this elderly lady, she had minimal symptoms. The CT scan showed a non-fibrotic HP type pattern. She took treatment for some time, but then when she got better, she was lost to follow-up. In 2019, she had come for a aortic valve replacement surgery. Again, as a pre-op evaluation, we had seen her. And CT again showed a acute HP type pattern. PFT had moderate restriction. She tolerated the surgery well. And then again during COVID time, this is a CT scan which shows the acute HP type pattern. So she was again lost to follow-up during COVID time. Then later on, she went and showed Dr. Abhay Upe. By that time, the disease had progressed. From acute, it had become chronic. Basically, from non-fibrotic, it had become a fibrotic HP. So Dr. Abhay Upe had started her on nintedanib and azoran. She did not tolerate nintedanib. She took steroids and azoran. And by that time, she had already started requiring oxygen therapy. So this is the CT scan. It had progressed from that acute pattern to a chronic HP type of pattern. So right now she is on azoran on tapering doses of steroids. She is requiring oxygen for 16 to 18 hours per day. She has taken the vaccination. Pulmonary rehabilitation has started, and her symptoms have become minimal now. So when we did her HP panel, it was strongly positive for pigeon dropping. PFT had showed a restrictive pattern. So she had severe restriction. In 2019, when the PFT was done, it showed moderate restriction that had now increased to a severe restriction. There was also a significant desaturation in the 6-minute walk test. And the DLCO was also showing a severely reduced DLCO, and the KCO was also reduced in this patient. So, learning point from this case is we need to avoid the exposure whenever we figure out that what is the cause of the antigen which is causing the disease. We need to avoid it, and we need to ask the patient to closely follow up so that timely intervention can be taken and we can prevent from acute to non-acute. Even if we would have probably given the treatment, there are some patients who can still progress to fibrotic hypersensitivity pneumonitis. So this is a third case. This is a 54-year-old female. She was diagnosed with asthma, and when she came, she was already having fibrotic hypersensitivity pneumonitis. She had symptoms since 2013. Multiple hospitalizations. She was already on nintedanib, MMF, and oxygen therapy, which initially she required only 1 to 2 liters of oxygen, and that kept on progressing to 4 to 6 liters. So she underwent the lung transplant evaluation, and progressively, unfortunately, she passed away because her disease had progressed a lot. This is her chest X-ray, and this shows fibrosis in the lower zones and areas of air trapping in the CT scan. I'll be discussing the CT scan in detail. So her hypersensitivity pneumonitis panel was also extreme positive for multiple antigens like fungus antigens and pigeon dropping as well. So what is the pathogenesis? Hypersensitivity pneumonitis is believed to be caused by an exaggerated response to the immune system. So, two people may be exposed to the antigen. If the patient has immune tolerance, then they may just get mild increase in local lymphocytes. But if there is a genetic or an environmental predisposition, or if they are basically, suppose if they are working and there is an exposure at work, or if there is an exposure at home and this keeps on continuing and they don't do anything about it, then it can lead to an exaggerated immune reaction. It can cause granuloma formation, and which can ultimately cause hypersensitivity pneumonitis. So basically it is a non-IgE mediated inflammation. There is type 3, type 4 hypersensitivity reaction. Initially type 3 occurs followed by type 4, and type 4 is one that is supposed to be associated with chronic presentations, and this eventually progresses to lung fibrosis. The antigens can be microbial, it can be plant or animal based proteins, inorganic, low molecular weight chemical agents, and exposure can happen anywhere. It can happen at home, it can happen at work, at recreational environments. And viral infections and other infections can cause an exacerbation of hypersensitivity, and this can lead to developing more progression of the disease. So both humoral and cellular mechanisms mediate this inflammation. Once the antigen exposure, following the antigen exposure and the processing by innate immunity, the inflammatory response is predominantly mediated by T helper cells and antigen-specific immunoglobulins. So basically, IgG antibodies lead to lymphocyte accumulation in the bronchoalveolar inflammation, which leads to granuloma formation and fibroproliferation. The role of genetics is not very clear, but MUC5B and RS35705950 have been associated with a worse prognosis and with more of fibrosis. So there are more than 300 antigens which can cause hypersensitivity pneumonitis. So most common are the avian antigens, the fungus, the thermophilic bacteria at home or in the working environment which can cause. So in more than 30 to 50% cases of interstitial lung disease, we may not even be able to identify the cause. Once we identify the cause, it is extremely important to make sure that those patients are basically get rid of that exposure. So these are a few of the most common ones. Moldy hay, which can cause farmer's lungs, compost, which can cause mushroom lung disease, moldy sugarcane, which can cause bagasosis. These are caused by thermophilic actinomycete spores. Then humidifiers, air conditioners, sauna, bird dropping, all of them can be caused by MAC. The list is endless. There are so many antigens which can lead to hypersensitivity pneumonitis. These are a few of them. So mainly fungus, then pigeon dropping, bird fancies disease, all of this is something that we see commonly. So what are the clinical features of hypersensitivity pneumonitis? So these patients may be more commonly seen in the 4th decade. They may be women. They could have acute or subacute symptoms and chronic symptoms. Acute symptoms could be symptoms like flu, like fever, chills, fatigue, chest tightness, wheezing, and they may not improve with a short course of treatment. And chronic symptoms could be longer, cough for many years, breathlessness on exertion. Even in patients with chronic symptoms, they even have clubbing. On examination, they reveal crackles, which are mid-inspiratory squeaks, and occasionally cyanosis may be seen and digital clubbing may be seen in advanced cases. So this used to be the previous definition. I've just included it for the sake of the signs and symptoms. So if the patient develops symptoms within 4 to 6 hours, they may develop symptoms of flu like cough, breathlessness, fever with chills, malaise, chest tightness, occasionally nausea. And then it can go to subacute illness where there will be an increase in the symptoms. There could be productive cough, dyspnea, constitutional symptoms, anorexia, weight loss. And in chronic state, there is fibrotic changes. So there is breathlessness on exertion. They may have cough with or without expectoration, malaise, anorexia, and they may have clubbing. And PFT shows progression of the restrictive lung disease. So why is it important for us to diagnose these patients early on? Because when the patient presents in the non-fibrotic fibrosis state, that condition can be completely reversed. So it's very important to take a proper history, try to find out what is causing the hypersensitivity pneumonitis, and hence prevent fibrosis of the disease. So what all investigations? How can you diagnose hypersensitivity pneumonitis? It is not just one modality. It is basically you have to have a clinical symptoms antigen which can cause the hypersensitivity pneumonitis, CT scan findings suggestive of hypersensitivity pneumonitis, PFT, DLCO, we do 6-minute walk test. Also, hypersensitivity pneumonitis panel, which includes a panel of IgG antibodies, can be done. And in some patients where the diagnosis is not clear, we can do bronchoscopy and, if required, lung biopsy. So, in non-fibrotic HP, the exposure is short and there is a high intensity of exposure. In chronic, there is a low level exposure over a long period of time. Symptoms I will not go into detail as I have already explained, and CT scan findings I will be explaining in detail in the subsequent slides. So how can you diagnose it? History and physical examination is extremely important, followed by lung functions. If there is any opacity which you see in the CT scan, if the patient is not improving, better to do a CT scan. CT scan really shows us, can really help us with the diagnosis. So what type of CT scan do we need in hypersensitivity pneumonitis? In all types of ILDs, we want supine, inspiratory, expiratory and prone position to see the which type of ILD we are dealing with. So this is from the ATS guidelines for radiological features of hypersensitivity pneumonitis. For non-fibrotic hypersensitivity pneumonitis, we can have typical HP pattern, compatible with HP pattern. So the typical HP pattern, we see signs of air trapping and we see centrilobular nodules. At least one of them should be present, and at least one of the following should be there for parenchymal infiltration, that is mosaic attenuation, ground glass opacities. These should be present to call it a non-fibrotic hypersensitivity pneumonitis. So if you can see the CT scan in the CT scan over here, there are parenchymal involvement, that is ground glass opacity, there is mosaic attenuation, then small airway disease is present, ill-defined centrilobular nodules are present, signs of air trapping is present, and the distribution is craniocaudal or it can be axial. So in this CT scan we can clearly see the centrilobular nodules. Over here there are centrilobular nodules. This is the air trapping. This is a triple density sign. In triple density sign, there are areas of air trapping, there are normal areas, and there are areas of mosaic attenuation. So there you can see three different kind of picture in this, giving it the name triple density scan. Over here, we can mainly see the ground glassing and mosaic attenuation. So when I was doing my residency, when our teachers used to tell us what is this mosaic attenuation, I used to get really confused. So mosaic attenuation, basically it looks like this tile. If you see the small area over here, it looks like this small cysts stacked together. So it looks like this mosaic tile. And this is the head cheese sign. Earlier the triple density scan was known as the head cheese sign. So this is the inspiratory CT scan and this is the expiratory CT scan. So it shows triple density. So over here also we can see a lot of ground glass opacities, centrilobular nodules, which are typical of non-fibrotic hypersensitivity pneumonitis. Over here also we can see those findings. So for fibrotic hypersensitivity pneumonitis, we can have any one of the following which shows a small airway disease. So we can have a triple density pattern, air trapping or centrilobular nodules. At least one of these should be present. And for pulmonary fibrosis, any of the following should be there. Coarse reticulations, traction bronchiectasis, honeycombing, and usually the distribution is axial and craniocaudal in typical HP pattern. In compatible with HP pattern, there should be signs of small airway disease and there could be a UIP pattern of fibrosis with extensive ground glass opacities, superimposed fibrosis, And then there are indeterminate for HP, in which you're not very sure if those CT scans look like HP. So these are typically fibrotic CT scan. There are triple densities over here, there is mosaic attenuation, there is ground glass opacities, and also there is areas of fibrosis. Other than that, we can do blood test to see the IgG. So there is hypersensitivity pneumonitis panel which can be done, which does a few tests, common tests which we encounter on a day-to-day basis. Just based on these tests, we cannot tell that the patient has hypersensitivity pneumonitis. It has to be clinical history with a history of exposure along with CT scan findings, and then if we have this test which is positive, this confirms the diagnosis. Just based on this, we cannot call a patient having hypersensitivity pneumonitis. So when do you really do BAL? Bronchoscopy, if we are not very sure of the diagnosis, we can do BAL. So with the lymphocyte, and we can send it for cellular analysis. If the lymphocyte is more than 30%, it is significant. So 20 to 30% is the cutoff for BAL fluid analysis. So this is the algorithm for diagnosis. If the patient is detected with interstitial lung disease and CT scan is done, CT scan is suspicious of hypersensitivity pneumonitis, we can do a BAL with or without transbronchial lung biopsy. And if there is a high confidence of hypersensitivity pneumonitis, then we can start the treatment. If the diagnosis is not clear, then we can consider, we do a multidisciplinary team work, and then we can consider transbronchial cryobiopsy or a surgical lung biopsy. So this is the diagnostic approach as per chest. It is similar to that, but in this you may not necessarily do bronchoscopy for all patients. If it is looking like hypersensitivity pneumonitis, then you can start the treatment of HP. When do you really do lung biopsy? Only when you are not clear of the diagnosis, that is when you do lung biopsy. So what are the diagnostic challenges? Basically, there is an individual genetic susceptibility, the type of antigen, the extent of the exposure, interaction with other factors like smoking, viral infection, drug exposure. There's a heterogeneous clinical presentation. The other tests that we do are PFT, DLCO, 6-minute walk test, ABG. Dr. Jayalakshmi has already spoken about this in detail. Treatment, first of all, there's no fixed treatment algorithm for this. You have to remove the inciting antigen. For acute symptoms, you give the treatment for 6 weeks to 3 to 6 months, depending on the patient's clinical condition. And for then later on, MMF and azathioprine can be continued if the patient is symptomatic or in case of worsening of disease. If there is a progressive pulmonary fibrosis, nintedanib is the preferred antifibrotic as per inbuilt trial. What is the supportive treatment in hypersensitivity pneumonitis? Vaccination, pulmonary rehabilitation, oxygen, and management of GERD, other comorbidities, and lastly, lung transplantation. In mild cases, they recover really well in a few weeks to a few months, but in severe cases, it can take 2 to 3 years for full recovery. But if they go into the stage of fibrosis, then they may require treatment lifelong. So the post-treatment guidelines are avoiding exposure of the causative agent, taking medications as advised, such as steroids, immunosuppressants, visiting the doctor regularly, monitoring, participating in pulmonary rehabilitation, maintaining a healthy lifestyle. If you're a smoker, smoking needs to be quit. So this is just a recap. There is fibrotic HP and non-fibrotic HP. Steroids and immunosuppression is the treatment. Antifibrotic is the treatment for fibrotic HP. Pulmonary rehabilitation, management of comorbidities, supportive care, and transplant for fibrotic HP. So the take-home messages is HP is increasingly common. In fact, there's a 5-fold increase in Mumbai due to the increase in the number of pigeon. So we need to make sure that the inciting antigens should be stopped, and the high level of suspicion is necessary to diagnose HP because it can be easily missed in the acute stages. A good history taking is extremely important, and a CT scan should be done whenever we are suspecting hypersensitive pneumonitis. In those patients where we are suspecting HP panel may be helpful, but just on the basis of HP panel we can't start treatment, and close monitoring is required. Thank you.
Any questions in the audience? Thank you, Dr. Bhumika.
Thank you.
Now I call Dr. Suhadeep sir for giving the token of appreciation to Dr. Bhumika ma'am and Dr. Prachi ma'am. Sir, please. So now we would move on to the next session on sarcoidosis by Dr. Arjun Ramasamy sir. I would like to invite the chairperson for this particular session, Dr. Divya Kukin ma'am. Dr. Divya ma'am is a consultant in the intensive care unit at Apollo Hospital with extensive experience in critical care medicine. Having earned her MD in internal medicine from Dr. B.R. Ambedkar Medical College, she has consistently demonstrated clinical excellence and leadership in the ICU team. So Dr. Divya ma'am has played a pivotal role in managing ICU operation training teams and even has led the COVID ICU with distinction. She is also an executive member of the ISCCM Mumbai branch. Now Dr. Divya ma'am will be introducing the speaker for this session, Dr. Arjun sir.
Good afternoon, everyone. Hello. Good afternoon, everybody. I would like to introduce Dr. Arjun Ramasamy. He is our consultant and interventional pulmonologist. He has over 9 years of experience in the field. He holds an MD in respiratory medicine, a DM in pulmonary medicine, critical care, and sleep medicine. Dr. Ramasamy has a profound expertise in addressing complex respiratory conditions, and his special area of interest is interventional pulmonology.
Thank you so much, ma'am, for your kind introduction. So, without wasting any time, we'll just, over the next 20-30 minutes, we'll try to understand this complex disease known as sarcoidosis. So, why discuss about sarcoid today in an ILD meet? Because ILD is one of the manifestations of this disease known as sarcoidosis. So, sarcoidosis is a generalized systemic disease of granulomatous origin, which can involve multi-systems. That is, it can involve your heart, it can involve your skin, lymphatics, of which in lung, ILD is one of the presentations, and hence sarcoidosis is classified as an exclusive segment in your ILD. So we'll just go through a few cases that we have seen so as to understand more about the same. So the first case is of a 32-year-old female. She presented with complaints of low-grade fever and fatigue since 2 months. She had loss of appetite and loss of weight, and the general physical examination was normal. The vitals were also normal. There was nothing remarkable in the systemic examination. This was her X-ray to begin with. So if you can notice, the parenchyma is relatively normal, so no ILD here. However, there are bulky bilateral hilar lymph nodes. So subsequent investigations revealed that subsequent investigations revealed an ESR of 40, a serum ACE level of 93, the Montauk's test was negative, and IGRA was negative. So this was the representative CT images, which shows non-homogeneous lymph nodes, homogeneous lymph nodes in both the hilar areas. So again, homogeneous enhancing hilar lymphadenopathy along with subcarinal paratracheal lymph nodes and a normal lung parenchyma. So as a next part of evaluation, we did a BAL, the AFB smear, cytology, CBNAT was all negative. The CD4-CD8 ratio, although not commonly done, since we are suspecting sarcoid and since this is a sarcoid topic, the CD4-CD8 ratio was 7. The TBNA, that is the EBUS-guided TBNA, showed epithelioid cell granulomas without necrosis, and the aspirate that was sent for CBNAT was negative. So what is the diagnosis here? So, I know we are talking about sarcoid, but over the next 4 questions, we'll try to figure out how to differentiate and how to identify sarcoid from TB, whether clinical features can help in differentiating, what is the role of laboratory investigations in differentiating the two, can radiology help in differentiating sarcoid from others, and what is the role of bronchoscopic modalities. So, clinical features are pretty much the same. The constitutional symptoms are non-specific. Respiratory symptoms may overlap. However, certain features like Lofgren syndrome, lupus pyreneo, Hertford syndrome are commonly encountered in sarcoid. So, these are 3 typically characteristic features that point towards sarcoid, which are high sensitivity. That is your lupus pyreneo, which are violaceous indurated plaques and nodules affecting the nose, cheeks, and ears. The Hertford syndrome, that is characterized by parotid enlargement, facial nerve palsy, uveitis, and fever. And Lofgren syndrome, that is the acute sarcoid, which presents with fever, erythema nodosum, and bilateral hilar lymphadenopathy. So again, clinical features are dubious. It can overlap. However, these clinical features point towards the possibility of sarcoidosis. What about laboratory investigations? What are the options that we have? So these are the 4 options in laboratory tests that we have to differentiate sarcoid from most common TB. So what is the role of your Montauk's test or your tuberculin skin test? It assesses cell-mediated immune status. Suppression of Th1 helper T cells are seen in sarcoid. There is suppression of delayed hypersensitivity reaction, and there is energy to TST, which remains high in sarcoid patients. So a negative TST has a high sensitivity for sarcoidosis. However, a positive test does not rule out sarcoid. So just remember that a negative test favors sarcoid. Now, again, just highlighting the same, a negative Montauk's test has a high sensitivity for the diagnosis of sarcoid. A BCG vaccination in childhood has no correlation with a negative Montauk's test. Now, what about IGRA, your interferon gamma release assays? So, the crux of the matter is a positive IGRA supports a diagnosis of latent TB. A negative TST, that is a negative tuberculin skin test, supports a diagnosis of sarcoid. IGRA can be positive in many patients of sarcoidosis, and IGRA may be more accurate to detect latent TB. However, this does not rule in or rule out the presence of concomitant sarcoid. So just to summarize, a negative Montauk's favors sarcoid, a negative IGRA also favors sarcoid. However, positivity in Montauk's and IGRA can be encountered in sarcoid also. What about serum ACE levels? ACE is an angiotensin converting enzyme. It is a membrane-bound protein which is expressed on the surface of endothelial, epithelial and dendritic cells. The membrane-bound ACE is converted to circulating ACE by proteolytic cleavage. And this is produced by your macrophages, epithelioid cells in granuloma. And it's not just in sarcoid, there are multiple conditions like TB, in fungal infections, silicosis, lymphoma. In all these conditions, ACE levels can be raised. So, in sarcoid, the sensitivity of a higher ACE level, that is more than 2 times the upper limit of normal, is about 60 to 80%, and the specificity also varies from 70 to 90. So again, ACE levels can be raised in multiple conditions. So serial values might be helpful in disease monitoring, and relapse is characterized by rising levels. What is the role of hypercalcemia and hypercalciuria? Any granulomatous disorder, there is activated mononuclear cells and macrophages, which leads to the conversion of calcidiol to calcitriol, and there is an increased calcium absorption which causes hypercalcemia. In sarcoid, hypercalciuria is seen in 30 to 50% and hypercalcemia in about 20%. In tuberculosis also, hypercalcemia is reported with a wide range between 2.5 to 20%. Now coming to our ILD part, that is, can radiology help in differentiating sarcoid from something else? So again, there is your mediastinal window and your lung window. So now just talking about the lymph nodes first. There is predominantly, usually a bilateral, symmetrical enlargement in sarcoid. However, unilateral lymph node enlargement is also reported, but it is less common. Hardly 8% is reported. Whereas in tuberculosis, it is usually unilateral, and bilateral lymph nodes are less common compared to sarcoid. Again, it is not a clearly differentiating feature. What about the morphology? Homogeneous lymph nodes with clusters of black pearls are suggestive of a possibility of sarcoid, whereas heterogeneous lymph nodes with rim enhancement, coagulation necrosis within the lymph nodes are features of tuberculosis. So, stuck again. Yeah. So on the left you can see sarcoid, which are homogeneous lymph nodes, and on the right you can see heterogeneous lymph nodes with possible coagulation inside, which is known as the coagulation necrosis sign, which favors tuberculosis. So, I'm not sure why this is taking so much time. Yeah. So coming to the lung window findings. So there are certain findings which favor sarcoid, such as your perilymphatic distribution of nodules, or your perifissural, perilymphatic pattern of distribution of nodules favors sarcoid. However, proper cavitation or something like a huge cavity is less common in sarcoid as compared to tuberculosis. Perihilar mass-like lesions are more common in sarcoid, whereas they are less common in tuberculosis. And fibrotic changes, again, sarcoid can present in later stages with just lung fibrosis. So peripheral honeycombing, diffuse nodular opacities are all possibilities in sarcoid, which is less common as compared to TB. So just showing a few CT findings. What you can see here are nodules. The nodules are beaded and they are distributed mainly along the fissures. So these are all perifissural, perilymphatic nodules, and they are predominantly distributed in the upper and the mid zone. So again, there are a few signs which are suggestive of sarcoid. So this is the classical sarcoid galaxy sign, and this is the cluster sign, wherein there is consolidation which is surrounded by small nodules. And the nodules are often perifissural and perilymphatic. So what about the pleural diseases? Pleural diseases are very less in sarcoid, hardly 5 to 10% are reported. And if there is effusion, it is an exudative effusion with a normal or maybe slightly raised ADA, and the CD4-CD8 ratio is also elevated in the effusion. However, you need to have for a definitive diagnosis, we should opt for a biopsy, preferably a thoracoscopic biopsy. Other features such as chylothorax, pneumothorax, pleural thickening, pleural calcification, are not specific for sarcoid. They can be seen in TB also. Now, what is the role of bronchoscopic modalities? So, in bronchoscopy, we first do the lavage. So, in lavage, the findings are the CD4-CD8 ratio is usually more than 3.5. The stains for tuberculosis are all negative. Then coming to EBUS, that is the lymph node biopsy under ultrasound guidance using a bronchoscope. So the tuberculous lymph node generally, as I told, have heterogeneous echoes texture with coagulation necrosis sign positive. So a combination of a positive tuberculin skin test, heterogeneous echo texture with the coagulation necrosis sign had a higher specificity and a higher positive predictive value for the diagnosis of TB. So the crux of the matter is, if we combine all modalities like an endobronchial biopsy with a TBLB with an EBUS TBNA, the combined yield is as high as 93%. And this is what a sarcoid histopathology looks like, which is composed of primarily non-caseating granulomas, which is composed of epithelioid cell histiocytes with oval nuclei and occasional giant cells. There can be few lymphocytes. The caseating necrosis, although very rare, it is reported in less than 10% of the cases. IHC histiocytes strongly react for CD68, and certain inclusion bodies are also heard of, that is your Schaumann bodies and the asteroid bodies. So this is a picture of a granuloma in TB, which shows a central caseation, whereas this is a compact granuloma in sarcoid, which does not have any caseation necrosis. So again, we clearly don't know if there is any link between TB and sarcoid. Sarcoid is a multi-system inflammatory disease which is characterized by the formation of non-caseating granulomas, which predominantly affects the lungs, lymphatics, and the skin. The peak incidence is between 30 to 50 years in men, 50 to 60 in women, with a slightly high female predisposance. There is a dysregulated immune response against one or more disease-promoting antigens. The inflammatory process to eliminate the offending antigen. There is a lack of conclusive evidence to say that sarcoidosis is caused by mycobacteria. Evidence, however, favors mycobacteria or their products are associated as triggers for sarcoid. Clinical similarities between TB and sarcoid always makes it very difficult to differentiate. Now, first, we saw a female of young age with fever, fatigue, and mediastinal lymphadenopathy. So now we'll see a second case of a 38-year-old female who presented with breathlessness, non-productive cough, and low-grade fever. There was no past history of TB. The general physical examination was unremarkable. So this is the X-ray, which shows left lower lobe opacity, right upper lobe opacity, and multiple enlarged lymph nodes. So the lab showed a raised DSR, a raised ACE level, a raised calcium level. The Montox was negative, and IGRA was also negative. So this is the representative CT cuts. If you can see the lung window here, the lung window shows a little bit of ground glass opacity and a little bit of mosaic appearance, so some form of ILD maybe, and the CT scan here shows enlarged lymph nodes. So subsequently this patient was subjected to a bronchoscopy with lavage and TBLB. So these were the findings. So since the patient presented with cough, expectoration, so we were not surprised when we saw mucopurulent discharge from the right upper lobe. The BAL CD4-CD8 ratio was 4. All tests were negative for TB, that is the gene expert and your ZN stain. However, AFB culture was awaited, and the TBLB showed a non-caseating granuloma. Subsequently, an EBUS also was done, and the EBUS also showed non-caseating granuloma. The aspirate was also negative for TB. So are we confident in making a diagnosis now? Somewhat, yes. So with all features, with a background, with such a with such a CT finding, and with all molecular tests being negative for tuberculosis, we labeled the patient as sarcoidosis. Started the patient on treatment. She improved slightly. However, the AFB culture came positive after 3 weeks. So the patient was started on ATT and steroids were continued. So in situations of dilemma, ATT and corticosteroids can be started concomitantly. So again, is this purely sarcoid? We don't know. Is this TB? Yes. So we treat TB and we give some form of an immunosuppression for sarcoid if it is indicated. Now this is another case of 53-year-old female who presented with dry cough and breathlessness. She had no constitutional symptoms, just dry cough and breathlessness. So again, this on an OPD basis, we'll always think of an ILD first. On a long-standing dry cough for 5 years, breathlessness progressive since 1 year. So on a detailed history, there was no seasonal allergies, no joint pain, no rashes, nothing to suggest a connective tissue disorder. There was a history of TB in her husband about a year back. And her past history was she was hypertensive since 10 years, and there was a history of hysterectomy 12 years back. The general system examination was unremarkable. Respiratory system wise, there was bibacillar fine inspiratory crepitations. So again, more in favor of some form of ILD. So this is a CT scan. So if you can notice here, the CT has some form of reticular opacities on both the lower lobes. The hyla also look a little congested, not really sure if to label them as lymph nodes. So we ordered a CT scan. So this is the representative CT scan. If you can see the lung window, you can see reticular nodular opacities predominantly in the mid and the lower zone, and you can see enlarged lymph nodes also. You can see multiple hilar, and enlarged lymph nodes. So again, we investigated, since we are dealing predominantly with lung-related issue, we went ahead with a 6-minute walk test. She walked an adequate distance of 440 meters. There was slight desaturation at the end of test. We did a PFT. PFT showed an obstructive pattern. And what we can see here, we did a Montague's test also, which was strongly positive. So just summarizing the other test results, the Montague's was strongly positive, ACE was elevated, calcium was normal, rest parameters are more or less within normal range. We got an ophthalmological evaluation also done, which was also normal. So do we have a diagnosis here? So in such cases, we definitely need a tissue diagnosis. So we offered the patient bronchoscopy, EBUS and all that, but the patient was not willing for any of those. And the patient took DAMA and went for a second opinion. Somehow the patient convinced the other doctor to start the patient on AKT. So since there was a positive, strongly positive Montague's test, big lymph nodes in a TB endemic region, although constitutional symptoms are not there, but still has got cough with expectoration since quite some time, so the patient was started on AKT. But the patient came back to us again after 2 months. This is the follow-up scan after 2 months. If you can see, the lymph nodes, hilar lymph nodes are exactly like that. There is no change in lymphadenopathy after finishing the intensive phase. And there is actually slight worsening of the ILD. There is more predominant, mosaic attenuation. The GGOs have slightly increased and her symptoms are pretty much the same, or rather she has worsened a bit. So this time we didn't have much difficulty in convincing her. She got convinced herself. So she said yes for a bronchoscopy. So we did BAL, which was negative for AFB. We did a gene expert again in the BAL fluid. That was also negative for AFB. And the culture, AFB culture, was awaited. And we did an EBUS TBNA also. And that EBUS TBNA showed non-caseating epithelioid cell granulomas with Langerhans types of giant cells. The TBLB also did not show any granulomas. And again, expert was negative. So do we have a diagnosis yet? Should we continue AKT? Should we stop AKT? Should we label it as steroid? So finally, we reviewed all the reports again. So in such a case where the patient is already started on AKT, it is always advised to continue AKT for the prescribed amount of time and start therapy for sarcoid. So we started her on a dose of 0.5 to 0.6 milligram per kg, 30 to 40 milligrams per day for initial 6 weeks. And the plan is to gradually taper over the next 6 to 12 months to a lower dose of 5 milligram per day as maintenance. And once the TB treatment is over and after assessing a response, then maybe we are justified in adding more immunosuppressants such as methotrexate or azuran plus minus HCQ along with continued supportive care and bronchodilators. So here the patient was labeled as sarcoid, but AKT was continued and she showed dramatic response with the initial steroids itself. Now coming to the fourth case, it's a 57-year-old female. She presented with cough, weight loss, wheezing on and off, and breathlessness, and she had a history of psoriasis. So this patient has got all symptoms: cough, constitutional symptoms, breathing difficulty, she has everything. So this was her chest X-ray. The chest X-ray showed a right lower lobe opacity. So this could be possibly pneumonia or a small pneumonic effusion, we really don't know. So subsequently CT was done, and this is the CT images. The CT images showed a well-defined mass-like lesion with maybe some speculated margins, and there were some nodular opacities and some tree-in-bud lesions are also seen. So looking at this CT and looking at the age and looking at the symptomatology, malignancy was her first differential. Subsequently, patient was subjected to a PET CT. And if you can see here, there are multiple lymph nodes in the neck, and there is a good FDG avid uptake in this primary mass-like consolidation. And this was the PET CT that was reported as a mass-like consolidation, and images are suspicious of a neoplastic etiology. So because there were lymph nodes in the neck, the patient was subjected to a USG-guided lymph node biopsy. And this lymph node biopsy came out to be a granulomatous inflammation. However, it was negative for TB, that was gene expert was negative, culture was also negative, her IGRA was also negative. So it was just reported as a granulomatous lymphadenitis. So do we have a diagnosis here? Some form of a mass-like lesion with granulomatous lymphadenitis on biopsy. So can we reach to a correct diagnosis? No, we need a few more tests. So again, We offer, so we cannot clearly say whether it is TB or not, whether it is just sarcoid or whether it is a malignancy, because granulomatous malignancies like lymphoma is also heard of. So we again offered the patient the requirement of a bronchoscopy and lavage with EBUS TBNA, because these are the top 3 differentials that we considered. But when we offered bronchoscopy, patient again was lost to follow-up, and she came back after 1.5 months. So since she came back after 1.5 months, we had to repeat a CT to assess for the disease stated, and the repeat CT also showed multiple confluent areas of consolidation in the right lower lobe. The mask-like consolidation was still present. So we subjected it to a bronchoscopy, and this was the BAL reports. The BAL was negative for TB. The AFB culture was also no growth. Both bacterial and fungal culture was negative. So instead of going for an EBUS, since there was a mass-like consolidation on the right lower lobe, we opted for a CT-guided biopsy, which was the most PET-avid lesion on the PET scan. So the CT-guided biopsy again showed features which were suggestive of a granulomatous inflammation. So now we were more confident in offering the diagnosis of a sarcoid, because we had done multiple biopsies, one from the lymph node, one from the lung, and we had done bronchoalveolar lavage also to confirm to rule out the presence of any tubercular bacilli. And subsequently, she was started on steroids. So this is the follow-up scan after 2-3 months. She was started on systemic corticosteroids, and the patient became better, and slowly the steroids are being tapered, and other immunosuppressants such as azoran is being added. So the final diagnosis here was systemic sarcoidosis with hypertension, diabetes, and hypothyroidism. So just a bit on sarcoid. Sarcoid is a multi-system granulomatous disorder of unknown etiology, which primarily affects the lung and the lymphatic system. It is characterized by non-caseating granulomas due to exaggerated immune response. Possible triggers include infection, environmental exposure, and genetic predisposition, or a mixture of all of the 3. There can be pulmonary involvement and extrapulmonary involvement. Pulmonary involvement predominantly occurs in the form of cough, which is mostly dry, breathlessness, and chest pain with fatigue. Extrapulmonary involvements, again, all systems can be involved, starting from skin, like manifestations being erythema nodosum, eye being uveitis, cardiac being arrhythmias, heart blocks, and neurological manifestations are also heard of. So diagnosis, like how we saw in the cases, imaging, X-ray, HRCT can guide us towards a path. Laboratory investigations like elevated ACE levels, hypercalcemia, hypercalciuria, and of course biopsy, which shows non-caseating granulomas to rule out mainly other diseases such as TB and fungal infections. And PFT can show both restrictive or an obstructive pattern or a mixed pattern. So in asymptomatic cases, wherein we have just picked up an incidental lymph node or an incidental mediastinal lymphadenopathy where the patient does not have any symptoms, we can just opt for observation. In symptomatic cases, steroids are the first line of treatment. Steroid-sparing agents like methotrexate, azathioprine can be added on case-to-case basis. In advanced cases, biologicals like anti-TNF-alpha have been used. And for end-stage disease, like how ma'am said, for all these progressive pulmonary fibrosis or for all of your PF-ILDs, lung transplant is an option for your end-stage fibrosis. So just this slide, just put this slide to highlight the spectrum of the disease, as in when treatment is favored and when observation is favored. So for any patient who is symptomatic, who has a PFT abnormality, who has low DLCO, who has organ function impairment, who has some form of progression, we should treat. Whereas if there are minimal symptoms, like for instance, for our first patient who just had fever and fatigue, we can actually opt for a wait and watch option over there, because the patient did not have any other constitutional symptoms. The patient's PFT was normal, DLCO was normal. So in such scenarios, we are even justified in just waiting and watching. So this slide I've just put here to highlight the groupings, as in the various modalities or rather various phenotypes that sarcoid can manifest with. There is low-risk sarcoid, which includes a Lofgren syndrome or just simple nodal sarcoid or scar sarcoidosis, or there are intermediate risk sarcoidosis wherein your organ, where there is bone involvement or there is uncomplicated uveitis, and then there is your high-risk sarcoid, that is your cardiac sarcoid, or what we saw in our case, like extensive pulmonary involvement with evidence of ILD, with restriction PFT, with or some form of a mass-like lesion. So all those are characterized as high-risk sarcoid. So yeah. So again, like I said, observation alone is sufficient when the symptoms are minimal, such in Lofgren syndrome. So this slide just shows the spectrum of the treatment modalities. For instance, for acute pulmonary sarcoid or just your Lofgrens, which is bothersome, we can just do with steroids in a tapering fashion. But remember, like the treatment duration for sarcoid is at least 1 year. So if we stop the treatment earlier, there are higher chances of relapse. So the addition of other immunosuppressant is based on the clinical context. For instance, if your sarcoid is complicated with uveitis, or if there is, functional impairment or cardiac sarcoid, you are justified in initiating more number of immunosuppressants. So what are the other options for immunosuppressants? So first line are always steroids. The second line drugs are methotrexate, azathioprine, leflunomide, MMF, HCQs. Then the third line agents are infliximab, adalimumab, and the fourth line agents are rituximab, JAK inhibitor, and even repository corticotropin injection has also been studied for sarcoid. Now just summarizing the $1 million question, whether TB or not. So again, all of these causes can be considered for a granulomatous lymphadenopathy. So based on your clinical context, once you try to narrow down your differentials, if nothing is fitting in, it is worthwhile going in and just evaluating for all of these causes based on your clinical scenario. It can be a bacteria, it can be a spirochete, it can be chlamydia, it can be rickettsia. All these can present with granulomas. Also your neoplastic diseases like Hodgkin's, non-Hodgkin's, and all your autoimmune diseases like SLE, all these can present with lymphadenopathy. So in countries with high incidence of TB should be considered as the first diagnosis of granulomatous disease. Detailed analysis and physical examination should be done to rule out other causes. MDR and XDR TB should be excluded, so that is the importance of going in for molecular-based tests. So finally, the take-home message is that EBUS TBNA and modalities are widely available now for lymph node sampling. Always divide the sample into two, send it for both histopathology and microbiological analysis. We should always think of common things first, that is TB versus sarcoid, followed by malignancy and others. So to conclude, how is sarcoid diagnosed? Sarcoid is always diagnosed in hindsight. Thank you.
Thank you, Dr. Arjun, for an excellent lecture. Any questions?
Yes, sir. What is it? MRI. Yeah, for cardiac, if there is a predominant cardiac involvement as seen by arrhythmias or heart blocks, cardiac MRI is the upfront investigation to diagnose cardiac sarcoid. It is the upfront investigation. Cardiac MRI is used. Yeah. Along with that, PET CT has also come up in a very huge way now. So PET can also be used in a similar fashion. But again, for cardiac sarcoid, cardiac MRI is the first line of choice.
No questions.
Thank you.
Thank you, sir, for very interesting case-based session. I would like to call Dr. Anand Mishra, sir, to provide the token of appreciation to Dr. Arjun, sir, and Divya, ma'am. So our next session is on end-stage ILD and COPD by Dr. Kapil Iyer, sir. I would like to call Dr. Kapil Iyer, sir, and Dr. Anand Mishra, sir, to chair this session. Dr. Anand Mishra, sir, is a senior consultant and internal medicine specialist with over 18 years of experience. He specializes in diagnosis and management of wide range of simple and complex medical conditions. He is a proactive member of numerous medical bodies. Dr. Mishra's contributions in field of internal medicine are further highlighted by numerous awards and published research papers.
Good afternoon, everyone. It's a pleasure and honor to introduce Dr. Kapilaya, who has been pioneer in starting lung transplantation in India, in Gujarat, and he has been trained extensively in lung transplantation in UK and more than 200 patients in various stages of lung transplantations. His areas of interest are ILD, lung transplantation, CLAP, and prevention of waitlist mortality.
Thank you so much, sir, for those warm words of introduction. Firstly, I would just like to thank Dr. Jayalakshmi ma'am, the entire respiratory team over here, Arjun, Bhumika, Pawan, for inviting me over here. I think we're coming towards the end of the CME, so I don't think so I'll be taking whole of 30 minutes. I would rather have a question-answer session at the end of my talk. So the topic given to me is to discuss about end-stage lung disease with a bit of pertinence towards interstitial lung disease and COPD. Now this is a topic which is very less discussed. There's a lot of controversies whether this should exist as a separate cohort, as a separate subspecialty. So what I'm going to do is I'm going to first start discussing what exactly do you mean by end-stage lung disease? What is the role of a pulmonologist while managing these patients? How are we supposed to address these patients? Setting off expectations between us and the patient as well as the family members. If the patients do agree for an aggressive sort of a management, what exactly does the word management include? And because I'm a bit biased obviously towards lung transplantation, I will definitely be talking about transplant logistics, which will actually include transplant windows, referral criterias, guidelines, and MDT's workup. And at the end of the day, what exactly do you mean by listing? So this is going to be the crux of my talk. So first, what do you mean by end-stage lung disease? Now, end-stage lung disease is nothing but obviously a severe form of lung disease which has reached the irreversible stage. The patient has already been optimized on medical management, not responding, and the basic functions of the lungs, which is oxygenation and carbon dioxide removal, are being affected. So this is the definition of end-stage lung disease. Now, it will really surprise you that the first definition, the first sort of an explanation, and the first paper towards an end-stage lung disease was all the way back in 1975. This was actually a radiological paper which actually mentioned the word end-stage lung. Unfortunately, this paper more described the morphological and the pathological changes rather than the clinical aspect. So what exactly do I mean by discussion? By discussion, I mean what is the role of a pulmonologist in dealing with these patients? So remember, the first consultation of these patients is extremely critical. This is not the time for us to talk about diagnostics like CTs and ABGs. Rather, we are supposed to have a lot of other parameters, basically what the patient understands of the disease process. Now, recently, British Medical Journal, in fact, published an article in which they said that 1/3 of patients who are suffering from chronic diseases have an extremely poor understanding of their disease. So we are looking actually at 33.33% of patients who sometimes are faltering in simple understanding of their disease. So this is actually the place where we sort of summate what is the disease we understand, what is the patient's understanding, and the family's understanding of the disease. It's very essential for us to understand what is the limitations, and I'm talking about physical limitations of these patients. There is a gross difference between ILDs and COPDs as far as limitations are concerned. Remember, as ma'am mentioned in her talk, ILD patients will start desaturating on movement. So somehow they are more comfortable in just being in one place because that's how they maintain their oxygen. It's a shunt defect. COPDs, on the other hand, do not have so much of a problem with movement as compared to ILD patients, and these are the patients who keep lingering on. But I will explain later why this activity limitation is so important for us to gauge. Psychology of a patient is extremely important. Remember, these patients are frustrated, they are anxious, they are irritated, they don't know what they are dealing with, and the basic fundamental functioning of their body is affected, which is breathing and oxygenation. So you have to take these things into consideration. And obviously you do glance on what medications the patient is on. Remember, geriatric societies all over the world in fact mention that our role at this junction is to knock off medications which are not important. Sometimes you see patients who come with 25, 30, long list of medications towards us, and obviously not all of them are required. So you need to be quite judicious when you're dealing with the medications of these patients. Now, even though the title reads comorbid optimization, see, we are the diabetic, we are the hypertensive capital of the world. Patients in their late 50s, 60s definitely will be having comorbidities. It's not important for us to just enlist the comorbidities. What we need to understand is, are these diseases leading to any other end organ damage? That is extremely crucial for us. Because when we actually consider these patients for transplant, the more organ systems apart from lungs which are damaged means a lesser chance that these patients ultimately will be transplanted. And obviously prognostic markers, in ma'am's talk she explained about the gap index which we use in IPF. COPD has got board index. So when you see these patients who've been through a lot, in your mind you need to understand what is the prognosis of this patient. You need to understand whether the patient and the family members are aware of this. And last is not something which we usually practice a lot because it's not medical, but obviously will and advanced directives. Now advanced directives, what I would like to pinpoint on is whether these patients and the family members are thinking more in the terms of non-escalation of treatment. And obviously, although it's not in the first consultation, but it's very essential, at least I do it. I just introduce the concept of organ donation, whether this concept has been breached with the family and with the patient, and then this can subsequently be taken off during subsequent consultations. Now remember, all these points which I have mentioned, it's not necessary that we need to approach everything in one go. Because sometimes you see patients will start zoning out when they're sitting in front of you. So this can be a period of multiple consultations, multiple follow-up. But at the end of the day, this is the page which is extremely important, in which we understand what are the expectations. Now remember, expectations, when I use the word, it's a fine balance, and we need to be very crystal clear in our mind. Is the patient and the family members looking for a conservative therapy, or are they looking for something more aggressive? And on the contrary, we see a lot of variety over here. Sometimes it's also possible that the patients want aggressive therapy, but clinically we feel they won't be able to tolerate it. And sometimes we feel that the patients do deserve a more aggressive form of management, but eventually they are not willing. So it's a very fine balance which we have to understand, but we need to make a call whether we are going for aggressive management or not. Because the further management completely depends on this. Now the further slides which I'm going to mention, they are assuming the fact that the patient has opted for an aggressive management. So what exactly do we mean by management? So these are basics which even a first year MD pulmonary medicine student will tell you, but believe me, I cannot emphasize more on this slide. All of these things have to be, spoken again and again and again. So things like smoking cessation, oxygen therapy, especially when you've got patients of interstitial lung disease, we know it's a shunt defect. On movement, their oxygen is going to drop. So you need to teach them how to use their oxygen, how to judicially use it. COPD patients, because it's a pump failure, so they might also be having CO2 retentions. So your home NIV also will come into play over here. Of course, vaccinations, diet, you need to maintain a certain protein balance in these patients. Remember, lung transplantation, we all know it's only exchange and putting of new lungs, but that's just the mechanical part. The new lungs are not going to inflate and deflate on their own. It depends on the strength of the respiratory muscles. So if your patients have got just muscle atrophy, especially their respiratory muscles, diaphragm, you are looking at a poor prognosis. So you need to take these things into consideration. All the previous three speakers spoke about pulmonary rehabilitation. It's one of the cornerstone managements of all the end-stage lung diseases when we want to subject them for a lung transplantation. Remember the basic, the more fitter or the more optimized your patient is before the transplant, the better is the prognosis, the shorter is the ICU stay, the shorter is the hospital stay, and obviously the lesser are the complication rates. So this slide is of utmost importance because we need to optimize this patient before lung transplantation. Now, since we are speaking about lung transplantation, I'm going to just pick on a few basics of what is a lung transplantation logistics, which all of us must be aware of. Okay, so the first is, this is a very, very, very important diagram. Now, usually if you just trace the path of the respiratory disease progression, sometimes it can be stable, sometimes it can just go down. So there is always a confusion. The confusion is, when exactly should a patient undergo a lung transplantation? There's always a confusion. So look at this diagram. If you see the yellow part, it mentions too early, which means the patient is quite decent. 6-minute walk distance is preserved. Lung functions are okay. The patient has not reached such an oxygen requirement that he needs a transplantation. So it's in the yellow zone. On the contrary, if you go to the red zone, it means your patient has already bypassed the window. So, usually 85% of the times we get referrals in which a patient is completely moribund. The patient does not even get up from the bed. The patient can't even do a 6-minute walk distance. They can't even do a DLCO. And that is when we get a referral for lung transplantation. This patient has already bypassed the transplant window. Okay. Now, what exactly is the transplant window, the area in green? It's very important. It is the time in the clinical progression of the disease when a patient needs a transplant, but the patient is fit enough to tolerate it. I will repeat this statement. Transplant window means a patient is ill enough to need transplantation, but fit enough to undergo the transplantation successfully. Now, whenever I usually show this slide, everyone understands this, but they always tell me, ki Kapil, once again, this diagram is a very subjective diagram, because my early can be your late, your early can be my late. So because of this, we have got numerous guidelines all over the world. This is the latest guideline which has been published by the Journal of Heart and Lung Transplantation. This is in 2021, which gives objective referral criteria of every single chronic disease. So there cannot be a gray zone as far as ILDs, as far as COPD, cystic fibrosis, bronchiectasis, pulmonary hypertension, LAM are as far as these diseases are concerned. So this is one of the most important document which we need to understand. Just to elaborate further, I'll just show you, these are referral criteria for interstitial lung disease. Now, if you actually go for it, the first point means that a patient has got a UIP pattern, because we know UIP patterns is a worse prognosis. Second is the lung function. So if your FVC is less than 80 or your DLCO is less than 40, remember, these are referral criteria, not transplant. This is when a patient needs to be referred to a transplant center. Third point obviously is the fall in lung function. So a relative decline in your FVC and DLCOs. Fourth is, once your patient starts needing supplemental oxygen, either at rest or on exertion, you know that the disease is progressing in such a state that he will at one point of time go down. Fifth is, inflammatory ILDs, and sixth is CTDs. We had a lovely talk, the first talk, in which Sir actually enlisted all the different rheumatological diseases. Now, rheumatological diseases are very tricky. This only mentions that they should be referred early because the rheumatologist, the transplant pulmonologist, the surgeon, they all need to sit together to discuss about the plans because they can be very tricky. For example, we know scleroderma, gastroesophageal reflux diseases. It can be very tricky because the patients will start getting rejection after transplant. And also in scleroderma, you can't use steroids judiciously because you're staring at a renal crisis. So you've got all of these discussions. So all this guideline mentions is let them be referred early and then the workup can be done and then the management can be done. If you contrast this referral criteria to the referral criteria of COPD. Now COPD, the first is board score, which is 5 to 6. Again board, I'm sorry. Okay, again, board score is something which all of us do it in our OPDs when we are looking at COPD patients. So board score of 5 to 6 with any of the following additional risk factors. So if your patient is a frequent exacerbator, if you feel that recently board index has increased by 1, if you are getting pulmonary hypertension on CT, your FEV1 is 20 to 25% predicted. I'll just come back to this later. Second is obviously you've got clinical deterioration despite maximal therapy, poor quality of life, which is unacceptable to the patient. And what this guideline mentions is usually a pulmonologist should refer for transplant and a bronchoscopic lung volume reduction at the same time. So criteria for both actually is the same. If you've got centers, if you've got expertise where bronchoscopic lung volume reduction can be done, that should be attempted first. And then we can once again come back to the question whether transplant is needed or not. Okay. Now, one thing you all would have noticed, look at ILD, FVC needed is less than 80% predicted. And if you look at COPD, your FEV1 is 20 to 25%. Look at the difference. ILDs make 80% requirement for referral. COPD makes down to 25%. The reason that this is being done is because there are multiple studies which show that ILDs, I'm talking about fibrosing ILDs obviously, unfortunately have got a very unpredictable course. Ma'am had a slide in which he mentioned about acute exacerbations of IPF. The 4-month mortality itself was so high. So these patients actually should be referred for lung transplantation early so that the understanding of transplantation with the patient and the family is already established, and then if they do have an exacerbation, at least they know things about transplantation. If you compare this to a patient who has absolutely no idea, patient already has got an exacerbation, patient is moribund, and suddenly I pop up and I start talking about transplantation, 99.99% this patient is going to say no. So that is the reason. COPDs on the other hand, they do wait for the FE1 to be 20 to 25%. Because these patients do linger on, the exacerbations in COPDs do not have a very high mortality compared to an IPF. So that is why these patients we can take time. Also, although I'm not a surgeon, but technically ILDs are a surgical nightmare because, you've got patients, the lung volume is completely collapsed, fibrosed, you've got dense pleural adhesions, you've got a lot of pleural bleedings, diaphragmatic dysfunctions, your hilar, your phrenic nerve anatomy is completely changed. If you see COPD, in fact, we always say if a surgeon wants to learn lung transplantation, the first 10 cases, you must always do a COPD. Because the lungs are hyperinflated. So when you open the lungs, the surgeon has got a lot of place, a lot of space in the thoracic cavity to perform his surgery. Hilar anatomy, phrenic nerve anatomy is always well preserved. You do not have pleural adhesions. So surgically also it is not as complicated as compared to an interstitial lung disease. But anyway, these are the referral criteria. Once a patient is referred onto a lung transplantation center, you've got all your history and everything. Now we've got something which is known as a pre-transplant assessment or a workup in which a patient is, different systems are completely evaluated. This actually needs almost like a 4 or a 5 day admission to a hospital, not because of worsening of your condition, but because you extensively need to work these up. So you need to see immunological antibodies, you need to see right heart catheters, right ventricle, as all of you know, is very essential for us. Rheumatologists need to see these patients whether anything can be attempted. Gastroenterologist for us is extremely crucial because you need to know about reflux, you need to know transit time, you need to know Demister scores, because reflux in the post-transplant patients means within 6 months you're looking at a chronic rejection. So this needs to be identified as soon as possible. Sometimes minimal reflux, we do the transplants, and 6 months to 1 year after the transplants, in fact, we have done fundoplications also once the reflux is not controlled. Obviously, these patients are very ill, so before the transplant, they can't undergo such an extensive surgery. But reflux is a bane for lung transplantation. So after that, obviously, once the patient is indoor, you've got a whole battery, a whole array of specialists who actually come and see these patients. Out of all the specialists, believe me, gastroenterologists, cardiologists, rheumatologists, intensivists, and infectious disease specialists, these are 5 who are really important, because you need to optimize all of these systems before even considering the patient for lung transplantation. And then comes the holy grail, which is MDT. Now, obviously, we've got MDT even for ILDs separately, but the MDTs for lung transplantation is a completely different ball game. It is very interesting, and I really want all of you all to attend this. Nowadays, anyway, all the MDTs are done on Zoom. So you've got your surgeons, your anesthesiologists, your intensivists, your pulmonologists, transplant pulmonologists, ID specialists, everyone sitting together. And thank God for Zoom, otherwise there will be a physical fight. There is so much of discussion, so much of back and forth, so much of arguments. The pulmonologist will push for transplant, the surgeon will say no. So there are a lot of things which we need to discuss on the MDT. See, I'll just give you an example. Sizing is a huge issue in lung transplant. It's not like heart, it's not like liver. Lungs sizing is a huge critical step. For example, if you've got a short female, let's say someone who's 145 centimeters height, female who's already suffering from ILD. So you've got a short female, already short thoracic cavity, plus a fibrosing lung disease. So the thorax is completely shrunken. Now you tell me how difficult it will be for us to get a donor whose lungs will fit into this. So I'm actually looking at a female donor who should be, let's say, 140 or 135 centimeters. So you've got so many of these discussions, even amongst males. For example, if you've got, let's say, Arjun and me, tomorrow I am brain dead, you can't put my lungs in Arjun, right? It will completely squeeze his heart and everything. You can't do that. So you have to actually plan all of this. And your surgeon actually over here is very important, and everything also depends on the donation rates which you see in your particular state. I'm going to give you some statistics. In India, 5 states have got quite a good donation rate: Tamil Nadu, Karnataka, Telangana, Maharashtra, Gujarat. So if you are in any of these 5 states, the chances of you getting a lung will obviously be much quicker. Maharashtra, unfortunately, is 4th with 2024 data of cadaver donation only in Mumbai was just 60 cadavers in whole year. So 365 days, we only had 60 cadavers. So it's a very sad state. So these are so many parameters, so many things which ultimately all of us need to take into consideration, and all of this will be discussed in the MDTs and subsequently further. So once the MDT is done, now comes the final step, which is listing of the patient. Remember, every state has got its own listing organization, plus you've got something which is called as NOTO, which is a pan-India level, it's a national level listing. Maharashtra is the only state where we have got, in one state we have got 4 different regional listing authorities. So you've got ZTCC Mumbai, ZTCC Pune, ZTCC Nagpur, ZTCC Aurangabad. So why is this so important for us to know is, suppose we've got a cadaver in Pune, that preference will be given first to residents of Pune and the patients who are listed over there. Only if they decline will this actually cadaver be open for us. Similarly, if there is an organ right now in Apollo Hospital, for example, ZTCC Mumbai will have the first priority. Only if all the hospitals in Mumbai decline, then this organ will go to ZTCC Pune, Nagpur and Aurangabad. If Pan Maharashtra they decline, it goes to Roto West. So Gujarat, Goa, Madhya Pradesh and Gujarat. If everyone declines, it goes all over India. And if everyone in India decline, only then does the lung be open for a foreign national. These are very strict guidelines put forth by NOTO and MOHFW. So this is something which all of us must know. So in conclusion, this is the entire journey which happens in end-stage lung disease. Remember, this is not a time for us to diagnostically challenge, the diagnosis and various things. We need to first understand what is the understanding of the patient. We need to assess their physical state, physical function. We need to understand how aggressive this patient deserves further treatment or how aggressive he is willing for treatment. And if there is, of course, we start thinking of lung transplantation. Please spare a thought, not only lung transplantation, but also ECMO. This also becomes a very critical discussion and a very critical decision. So that is extremely critical. So yes, end-stage lung disease is a separate subspecialty. It probably in 5 to 10 years, this will emerge as a separate cohort. It is an arduous approach which is necessary per consultation. It's easily at least 45 minutes to an hour. It's extremely crucial to understand which patients deserve an aggressive approach or lung transplantation or an ECMO. And lastly, of course, we need to establish more centers of excellence. The ideal approach will be first to develop an excellence of end-stage lung disease, get a simultaneous heart transplant program running, and then jump into a lung transplantation. Thank you so much.
Questions?
Sir, please.
What is the cost of the transplant? Second, what is the maximum in India and maximum international?
So you're talking about the maximum numbers in India, maximum in... Okay. So, sir, I'll answer each question separately. So the first cost, so the roughly cost is between 35 to 45 lakhs, which is more of a 21-day package. So it is not only the cost of the transplant, we never give it that way. So this includes your surgery, this includes the cost of every specialty which is involved, this includes a 7-day ICU package, a 14-day ward package, this includes your immunosuppression, antibiotics and everything, this includes the usage of your nitric oxide and obviously ECMO intraoperatively. So roughly this package is between 35 to 45 lakhs. Also it depends on what transplant you are doing. You can do single lung transplant, you can do double lung, you can do heart lung. This is the first thing. Obviously you have to understand that the more a patient stays in the hospital, the bill keeps on escalating, which is why I was stressing on the fact that before the surgery, the patient has to be optimized. That's the first part of your question. Second part is all over the world and in India. So in India, we've got Hyderabad, which has emerged as the current potential lead for doing the maximum number of lung transplantations. In India, I think they have done more than 450 to 500 lung transplants. It's a mix of heart lung, double lung and single lung transplants. Whereas in the world, it is actually Toronto General Hospital, so TGH has reached such a level that they perform approximately 250 lung transplants per year. They've got an excellent network, they've got an excellent organ donation rates. And this time in Indian Society of Heart and Lung Transplant, we in fact had invited a professor from there who actually gave a talk. They have now reached a level in which they are using drones for organ donation and all, so drone-based delivery of the organs. So we are still very far from that. But in India, approximately, if you see across all centers, on an average, anywhere between 40 to 80 lung transplants are being done every year. Hyderabad number 1, Chennai is number 2, Bangalore is number 3, and hopefully Pune is number 4, and hopefully Mumbai comes as number 5.
Any other questions? Please.
How is the success with the lung transplant especially for ILD patients?
Okay, so lung transplantation, so again I answer your question in two parts. So first of all, lung transplantation success rate, we don't give you one single number, it's more of a percentage. So 1 year success rate after lung transplantation is approximately 85 to 90%, 3 year survival is 75%, 5 year survival is 55%, 10 year survival is 35%. Which means, if today you do 100 lung transplants today, after 1 year 85 will be alive, after 3 years 75 will be alive, after 5 years approximately 55 will be alive, and after 10 years approximately 35 will be alive. Remember, these are all ISHLT, so International Society of Heart and Lung Transplant data, in which they have cumulated everything all over the world. In India, sadly, despite the number of lung transplants being done, we do not have even one position paper which reveals what is the Indian data. So I will not be able to comment on that. That is the first thing. Second, you asked what is the survival in ILD. So there was a lovely paper which was published in Journal of Heart and Lung Transplant, in which they compared every single disease undergoing a lung transplant and survival. The best survival is cystic fibrosis. The worst survival is IPF. Why is cystic fibrosis so good? Because usually these are patients who are young. They undergo a transplant when they are 15 or 18 years old, so they are physiologically much more compatible. Of course, they have a lot of extrapulmonary issues, so gastro issues, absorption
issues, both issues, but they tend to have a very good survival. IPFs, unfortunately, and not only transplant, in general, in respiratory medicine, if you ask all of them, IPF actually is one of the worst diseases. Because once you get it, your survival is actually on a downward trend. I'm talking about IPF, not other ILDs. IPF particularly. Even after transplant, unfortunately, they don't do very well because they've got a very unpredictable course. See, you have to understand, IPF, if you diagnose right now, straight away refer to transplant, no one will come. So they will at least take 1 to 2 years. By 1 to 2 years, unfortunately, they are already on a decline, and then you do a transplant. Then you have to wait for 6 months to 9 months to get an organ. So you're already going down, and then you do a transplant. So survival statistics wise, IPF is the worst. Any other queries? So there are again two concepts in this. First is known as a surveillance biopsy, which is again very different in every center. The place where I was trained, we used to do surveillance biopsy 6 weeks, 3 months, 6 months, and between 9 months to 12 months. This was the protocol which we used to use. Now there are a lot of centers which are not doing surveillance biopsies. They do something known as an as needed biopsy. I personally don't agree with that. But you've got these various blood biomarkers in which they send the blood test. If the blood test is actually normal, don't do the biopsy. If the blood test is abnormal, then go ahead with the biopsy. Unfortunately, international guidelines do not support this. There is no international published paper which supports this sort of way. So if left to me, I will still go ahead with surveillance biopsies.
What is the common reason for failure post-transplant in India?
So again, there are two things in India. You asked in India. So in the West, it is chronic rejection. More than 50% of the cases because of chronic, which is known as CLAD. So that is the most common cause of death. In India, it is infections. So because the West does not have the same MDR microflora and organisms which we see, 80% of the donor calls which we see, by the time you go, you do a bronch over there, you see all secretions coming, you send the sample, but you cannot wait for the report. This lung is already implanted. Day 3, you will get that there is some sort of an MDR Klebsiella. Abhi aapne to transplant kar diya, so you still have to somehow manage this with antibiotics. So it's a huge challenge. The toughest period in lung transplantation actually is post-operative. Your first 14 days after surgery is also not as difficult. It's the post-op ICU, which is very, very important. Any other questions?
Do we do artificial lung transplant?
No, till now, no. So there are two things in this. The first is you've got a living lobar lung transplantation, which is again being done in a lot of centers. This was first attempted in Los Angeles, UCLA, and this was pioneered in Japan. So University of Kyoto, his name is Dr. Hiroshi Date. He was doing a lot of living lobar lung transplant. So if you've got a child, let's say bilateral bronchiectasis, so you take one lobe from father, one lobe from mother, और बच्चे का राइट साइड में फादर का आपको ट्रांसप्लांट करना है, लेफ्ट में मदर का करना है. सो दिस इज नोन एज लिविंग लोबर. सो यू एक्चुअली
do not depend on cadavers for this. In India, there has not been even one attempt because this is immunologically a huge challenge. We already suffer from immunological changes and challenges. We see a lot of antibody-mediated rejection. Here, in the kid, you will have certain immunology coming from father and certain from the mother. And technically, you need expertise for that because there are 3 OTs running. So not only the lead surgeons, you need very good thoracic surgeons, Aju also. So you need a well-formed team, and it is quite difficult to do that. This is the first part. Second part is
xenotransplantation is on the rise. Till now, we have all read in the paper also that they tried a pig's heart for heart transplantation. In fact, 6 years back in Assam, this was tried. But at that point of time, unfortunately, the surgeon who did it, his license, there were some issues or something, ethical issues or something. But now the world is moving to xenotransplantation. So pig's heart is being tried. There has been no attempt till now to do any xenotransplantation of lungs. Any other question?
Thank you.
No?
Thank you, Dr.
Now I would like to call Dr. Varsha Vadra ma'am to give a token of appreciation to Dr. Kapil sir and Anand Mishra sir. Ma'am, please. So now we'll move on to the next session on allergic bronchopulmonary aspergillosis by Dr. Pavan sir. I would like to invite Dr. Suvadeep Sen, sir as a chairperson for this particular session. Dr. Suvadeep sir is a consultant in critical care medicine at Apoll Hospitals, Mumbai. Sir holds an MD degree and he is a gold medalist as well. He further specialized with an FMB in critical care and the prestigious EDIC qualification. He has also completed a diploma in ECMO from Paris. So Dr. Suvadeep sir has also contributed to several research publications and is actively in teaching as a DNB and an IDCCM faculty member. We are honored to have him chair the session today. Sir, please. Now Suvadeep sir will introduce the speaker for the session, Dr. Pavan sir.
Thank you, Dr. Harris, for the kind introduction. I will introduce Dr. Pavan Harris for the last one of today's CA. So Dr. Pavan Harris is one of the very good friend and colleague of mine, very enthusiastic, very academician. He is a senior consultant, he is working as a senior consultant in Apoll Hospital, Mumbai. Along with that, he is also associate professor in Tata Memorial Hospital. He has done his DNB pulmonary medicine with gold medal, he has an advanced training in interventional pulmonary from Bangalore. He has developed diploma in advanced respiratory medicines from Switzerland and fellow international pulmonary and thoracic endoscopy from Italy. He is a very avid international enthusiast for the international pulmonary procedures. He has a lot of pioneering works in pulmonology. He has multiple research papers and published papers in his credit, and he is a co-founder and faculty for the fellowship in pulmonology in KS Mumbai. Over to you, Dr. Pavan.
Thank you, Swadeep, for that kind introduction. And outside, I thank Dr. Jayalakshmi, Dr. Bhumika for having me here. It's little off the track from the ILD. We are talking about some allergic bronchopulmonary aspergillosis. So I'll try to wrap up the talk in 20 minutes. We are talking about ABPA. It's not a fungal infection. It's an allergic condition. It's a reaction to the aspergillus, which is naturally colonized in our airways. So why does it bother us so much when fungus is already colonized and we are living with that. Why we are talking about it? Because it complicates all the common respiratory conditions, asthma, COPD or bronchiectasis. The management differs from the routine disease. Asthma management, you rely only on inhaled corticosteroids or oral corticosteroids. Here the management differs. It alters long-term prognosis of a common respiratory disease. And when it is left untreated, patients lands into, most of the times they land into end-stage lung disease. And we need Kapil's help in that situation to manage those cases further. India, in fact, we are leading in most of the infectious disease, but in ABPA also, it's twice the global burden of ABPA, and I think we are the leaders even in the research, and most of the work is done by PGI Chandigarh. Even the international guidelines are headed by PGI Chandigarh, so we take pride in that. So this 1952, first time the ABPA was described, and then n number of guidelines, n number of criteria have been released. Because this condition is sometimes difficult to diagnose, it mimics the common respiratory condition, so we should not miss it, and that's why the guidelines have evolved. Last year we got the consolidated guidelines from the International Society of Human and Animal Mycology, and those are the guidelines we are going to follow in next few slides. So to diagnose an ABPA, we need three conditions. One is predisposing respiratory illness. Patient has the problem of respiratory system, comes to you. We have some radiological features, and all that depends on fungal allergy or immunological diagnosis to reach the diagnosis of ABPA. The pathophysiology has allergic component, eosinophilic component, and a fungal component. Fungus enters, eosinophil as well as IgE plus interleukin pathway gets activated, and patients develop a hyperallergic response to fungal pollens. So what are these predisposing conditions? Commonest asthma, COPD, bronchiectasis. We don't see cystic fibrosis so commonly in India, but asthma, COPD and bronchiectasis is the major situation where you need to look for whether the patient has concomitantly ABPA or not. Commonest symptoms, simple respiratory symptoms. Patients will have wheezing, cough, breathlessness, hemoptysis. Sometimes they cough out blackish material, and that was a criteria earlier, minor criteria to diagnose an ABPA. Or most of them just come as asthma, stable, asymptomatic, but X-ray shows there is a patch. So these are the commonest situations where you need to suspect there is a ABPA, this patient has ABPA or not. Regarding fungal sensitization, any allergy markers should be investigated in those patients. The commonest one is eosinophil, total Ig, and for fungus specific IgE or IgG. For ABPA, we use the IgE and IgG targeted against Aspergillus fumigatus. Various antigens are available. A cocktail of antigen is most of times used when you do a blood test. So let's talk about this IgE. So Aspergillus fumigatus specific IgE is the first test what you do. It's a hallmark test. Its cutoff used at various labs is different. So cutoff should be around 0.35 kilo units. Few labs will give you cutoff of 0.1. You have to inform your lab that what method they are using and try to convert those results into these units. It is extremely sensitive test, 100% sensitive. So it is a rule-out test. If the asthma patient suspected ABPA total IgE against the Aspergillus fumigatus is negative, no ABPA in that situation. If it is positive, investigate this patient further. So it is a very good screening test, but it's not used for follow-up. Even if the Aspergillus IgE level comes down, it doesn't mean the patient has responded to the treatment. Once positive, it should be considered as patient has some kind of fungal sensitization, and let's investigate it further with other tests to confirm the diagnosis of ABPA. So next test is precipitin antibody, IgG antibody. Long-standing exposure to the fungus will give to IgG antibody. So it should be done in enzyme immunoassay test. Cutoff is for India is 27. So a patient coming from abroad, from Kenya and all those, they will follow a different cutoff than Indians. The sensitivity is 89, specificity 100. It means when it is IgG is positive, it means patient has got exposure to the fungus for sure. Then you have to combine IgE, IgG result with further other test to come to a conclusion of ABPA. Total Ig, the cutoff used is 1000 as per the ISHAM guidelines. It is a good sensitive test but very poor specificity because Ig can be high in any allergic condition. It can be used to follow up the response to the treatment. You have given the patient steroids, you think clinically patient is better, PFT is better, radiologically better, and if your total IG level comes down more than 20%, it means we consider this patient is responding to the ABPA therapy. They're useful for initial diagnosis as well as follow-up. And if there is exacerbation, when you call it ABPA exacerbation, one of the important component is your total IG level has doubled up, more than 50% of the normal cutoff, what you have used. Suppose today patient comes in and he has 1000 IgE, and when there is exacerbation, it is 1500 or 1800. That is the situation you call it as there is an ABPA exacerbation as well. Aspergillus skin test, lot of allergy skin tests have been done, out of which aspergillus is one of the component. It is based on the extract from the fungus, given intradermal or skin prick test. Intradermal is the preferred one. But problem is that we need standardized molecule to check for the antigen sensitivity. You need a trained person. It can cause anaphylaxis, and the sensitivity is as good as 88 to 94%. So it will pick up the disease. Problem is that if it is not a standardized dose or not properly performed, you will miss at least one patient out of 10. So it is not recommended routinely unless you don't have an option of doing a blood Aspergillus specific IG level. Eosinophil count, again, it's not very specific. Any allergic condition, even the Ascaris or any other parasite infection can give rise to eosinophil, and eosinophilic disease as well. But so it is one of the supplementary criteria. When it is more than 500, you should consider that yes, it will contribute to the diagnosis. Regarding radiology, the X-ray is most of the times non-specific. Either you get fleeting shadows, it means one day patient has come to you, has right-sided opacity, 1 week down the line patient has left-sided opacities, and the opacities change their location as well as the characteristic. Fingering glow and bronchiectasis are theoretically described. You may find it in few situations, but CT scan is very sensitive in diagnosing this condition. So you have to look for on CT scan bronchiectasis, nodules, mucus, or something called as pleuroparenchymal fibrosis, which is an advanced stage of this disease. High attenuation mucus, one of the characteristic or pathognomic feature of ABPA, when it is present, even the other criteria are negative, still you can diagnose an asthma patient with HAM as an ABPA condition. Radiologically, it is classified at multiple, many authors have described it. The commonly used is, something called as ABPA, I'm sure one slide is missing here. ABPA S means there is no radiological finding, and you have serological test, IG and IgG positive. Then comes is the mucus impaction, where a lot of mucus is present in that situation. You have there's some change in slide this thing, but when you have bronchiectasis, it's ABPA B. The last picture is not actually ABPA CF, it's ABPA B. When the CT is normal, is ABPA S. When there is a mucus impaction, you have a consolidation like change. And when you have something called as high attenuation mucus, where this is the corner one is the high attenuation mucus. You have to compare with the paraspinal muscle opacity, and if they match, that's a high attenuation mucus. That's how we differentiate it from mucus impaction. So Isham, we have seen the radiology, we have seen the immunology and clinical presentation. When a patient comes to you, do I need to do everything? No, you have to look at certain characteristics, certain criteria, and it's very algorithmic approach that you need to have a predisposing condition, and we talked about asthma, COPD or bronchiectasis or cystic fibrosis. You need to investigate for fungal allergy, and the commonest test done is, as I told you, screening test is Aspergillus specific IgE, and then if the cutoff is matching, you have to investigate this patient further, do a total IgE, and if it is crossing more than 500, these two criteria are mandatory to diagnose an ABPA. Then there comes the supplementary criteria, which is, we talked about IgG. If IgG is positive, if you have blood eosinophilia, your diagnosis is sufficient. At least 2 out of last 3 criteria are required. If your CT scan shows there is a bronchiectasis, there is a fleeting opacity or a HAM, it confirms your diagnosis. Suppose you are not meeting. So in clinic, when it comes to you next time, asthma patient has to be investigated for fungal allergy, or a bronchiectasis has to be investigated for fungal allergy. And we routinely advise something called as ABPA panel. It contains IgG, IgE and total Ig all together done in one prick, so that you have X-ray done for your patient is clinically symptomatic and 2 other criteria come positive, you are done with your diagnosis. Suppose patient doesn't have a classic clinical symptom, but has radiologically mucus plugs, coughing out mucus plugs, or some blackish material, or there is unexplained collapse on the X-ray in asthma patient, investigate it further. If you don't have Aspergillus specific IgE, then skin prick test is done. Otherwise, we don't do skin prick test. Even total Ig level less than 500, but your other criteria are satisfied, consider this patient as a diagnosis of ABPA. And most of times we do immunoassay or a lateral flow test. Always look at the bottom of the report what test has been, what method has been used for diagnosis in a particular lab. And if you have a ham, you don't need other criteria to come to a diagnosis of ABPA. So if the patient comes to you, first test you will do is Aspergillus specific IgE. If that is positive, do total IgG as well as blood eosinophil count. And if that is positive, please consider a CT scan in your patient, because that will tell about only serologically positive ABPA or there is a radiological abnormality as well. So bronchiectasis, mucus plugs, ham, and a chronic fibrosing disease is what we looked at on the CT scan. So how we manage it? Every disease management is relieve the symptom, control the progression of a disease, and prevent the relapses, prevent the exacerbation. That's the aim of the treatment. So in treatment of ABPA, there are two options we have. Either you reduce the immunological response. It's an allergic disease, so you reduce the immunological response. The standard drug is corticosteroid. Apart from that, you have biologics. If you want to reduce something else, reduce the fungal burden, and that's something where antifungal medications come in picture. So combination of medications can be used when you are dealing with a difficult case of ABPA. Otherwise, most of the patients respond to corticosteroid therapy. Various regimes have been proposed. What I personally use is 4 weeks therapy with 0.5 milligram per kg per day, and then you reduce the dose to half for another 1 month, then further reduction to half in another 1 month, and after 3 months of therapy, start tapering the dose. Simultaneously, you look for the side effects of the steroids, sugars, osteoporosis, other things has to be managed simultaneously. A methylprednisolone or Defcort has been used. When you are using methylprednisolone, remember your antifungal use simultaneously will increase the viability of methylprednisolone. So you may have to reduce the dose of methylprednisolone when you are using antifungals simultaneously. Commonly used antifungal, and there is one paper available which is solely used itraconazole in management, and that's the drug of choice in antifungals. 200 milligram morning, evening for 4 months, given along with meals, will improve your therapeutic level. The therapeutic drug monitoring is performed in these situations. At the end of 1 month, we always look for whether the drug level is reaching properly, and then you continue the doses further. Super bioavailable drug may not be available in all the centers. Voriconazole is other drug of choice, should be given empty stomach. And then isaconazole once a day prescription is also available. We don't have RCTs comparing one drug versus other. Other antifungals that includes posaconazole, amphotericin, nebulized form. These are other drugs available but not commonly used. They are reserved for when your antifungal medications are responding, patient is a resistant form of ABPA. In that situation, you may consider using that. Regarding the biologics, it is done when you have treatment dependent ABPA. You are trying to reduce the steroids and patient exacerbates. In that situation, you can consider using biological therapy. And those who are refractory cases of ABPA, whatever you have done so far in a period of 6 months or 8 months, patient is not responding. And we have a couple of patients who are becoming eligible for one of the biological therapy. What we have is mepolizumab, Omali, Benrali, and Dupilumab. We have 3 drugs, top 3 drugs available in India at present. So the decision for biologics is not clear. It depends on individual doctor's preference and the total Ig level as well. So you look at allergic, eosinophilic, and fungal component. Eosinophilic component means what? You have mucus plugs, you have ham, rich in eosinophil. Or you have an allergic component which means serology positive disease. Where the serology positive disease, you may use an anti-IgG, that is omalizumab. Other conditions, anti-IL-5, that is mepoli or benralizumab is used commonly. If you have option of using dupilumab or tezepelumab, all are weird names, not available in India at present, but that's the probably going to be a drug of choice for resistant or treatment dependent cases of ABPA. I'll just take you through few clinical cases, what we have learned so far. Let us take you through these cases we have come across in last couple of years. So a young male came last year, young male, childhood history of recurrent cough, colds, allergy to dust, allergy to strong perfumes. His father also gives the same history. So the clinical diagnosis of asthma is in picture. He presented with 1 week history of breathlessness, wheezing, sneezing, bilateral polyphonic wheeze, blood test are normal. CT, if you look at the X-ray, roughly normal except some prominent vascular markings. We have treated this patient, is in VZ patient, acute exacerbation like symptoms. You treated with oral corticosteroids, but simultaneously ask for blood test, because once you give steroids, your eosinophil and total Ig level will come down. So the first day only you should screen these patients for fungal allergy. After 2 weeks, you see there is obstruction, but lung functions are quite good now, mild obstruction. His peripheral eosinophil count came as 800, aspergillus specific Ig, total Ig, and fumigatus IgG, all of them are positive. Eventually, you have to do CT for all the patients, because if you strongly suspect ABPA, you have to characterize them further whether the patient has bronchiectasis or not. The CT is normal. So this is a ABPA serologically diagnosed, ABPA S case. No bronchiectasis or no radiological finding. Now, do all the patients require longer course of steroid? Do all of them require antifungal medicine? No. If they are clinically asymptomatic, well controlled, treat them as an asthma patient with inhaled corticosteroids with a LABA, like formoterol budesonide with combination, or any flutic acid like inhaled corticosteroid you prefer. The next case is a case of 61 year male, multiple problems, TB history, gastric ulcers, bleeding, piles. He has undergone multiple surgeries. He is a hypertensive, IHD, antiplatelets, has creatinine on a borderline, non-oliguric, CKD3. He comes to us with frequent respiratory infections. He has seen multiple doctors. 1 month history of breathlessness, cough, and yellowish expectorants. Standard respiratory symptom, you suspect there is a lower respiratory tract infection in this patient. You do an X-ray. X-ray doesn't show anything except some area of linear opacity with cystic changes in the left lower zone. His blood investigations are normal except creatinine 1.3. PFT shows severe obstruction. Now, bilateral crepitations, bilateral wheezing, treat the patient with antibiotics plus steroid, whatever combination you use, but investigate it further. So this patient showed multiple areas of bronchiectasis. You can see, cystic bronchiectasis changes and linear tram-tack appearance also in one of the pictures. So ABPA workup, all three things, total Ig, aspergillus specific Ig, and IgG, all came positive in this patient. Simultaneously, there is a kidney illness, so we thought there is a proteinuria, investigate this patient further. It came positive for amyloid as well. So don't know it is a primary amyloid versus a bronchiectasis reaction. And he was positive for PSA also because of his urinary symptoms, came out to be a prostate cancer. Now severe obstruction, ABPA, diabetes, gastric ulcers, antiplatelet, bleeding history. How to manage? You manage the airway obstruction with nebulizations or inhaled corticosteroids and tiotropium in combination when there is a severe obstruction, but simultaneously consider steroid versus antifungal therapy. Now looking at the steroids, his diabetes uncontrolled, he will have difficult sugars to manage. He has peptic ulcer issue, the steroids will exacerbate that. He is on antiplatelet, another bound of bleeding may happen. So consider antifungal in such situations. We use itraconazole, only itraconazole after the initial short burst of a steroid for 2 weeks. For 4 months, the patient improved very, very well. He even underwent a prostate surgery, which was a malignancy, and he is still making a good follow-up with us with exacerbation-free and well symptom control. The other case is from Tata, is a 50-year male cigarette smoker presented to us with right upper lobe mass. On CT scan, you can see there is a right upper lobe mass. He has 2 months history of right-sided chest pain, cough, and shortness of breath. CT scan, there is a right upper lobe mass. You can see in the mediastinal window as well, but there is something else on the left side. And this thought to be a metastatic disease on the left because it is mimicking the soft tissue density. So this patient underwent further investigation. As a protocol for a lung cancer, you do MRI brain and PET CT for look for metastasis. So there is high avidity on the right upper lobe mass, but when you look on the left side, there is no avidity at all. So this patient, further CT analysis, you can see there are some areas of bronchiectasis and mucus plugging. And if you can look at the leftmost corner, there is a high intensity, there is high attenuation seen in this area. So this high attenuation area is actually an ham. So it looked like a lung mass, maybe a metastasis, but because of the mucus plugging and background attenuation, you suspect there is something else happening in this patient. No respiratory symptoms, only no respiratory symptoms of obstructive airway disease, breathlessness, wheezy illness, or a bronchiectasis earlier. So this patient is a lung cancer. You have a right upper lobe mass, MRI negative, PET-wise there is no other metastasis, but few lymph nodes are writing up. This patient was roughly stage 3B, was planned for chemoradiation therapy. So he was referred to pulmonary medicine, and look at this. There is no respiratory infection history or airway disease. PFT has only small airway obstruction. There was eosinophilia. So we got his total IG done and Aspergillus specific IgE. Both came positive. So further did an IgG as well as CT showing an ham. So we went ahead with bronchoscopy. Now bronchoscopy is not needed in all the patients, except a situation like lung cancer where we want to rule out any endobronchial lesion causing post-obstructive pneumonia and obstruction. So you can see there are a lot of mucus plugs on the left upper lobe. We removed those mucus plugs. On histopathology and culture showed Aspergillus fungus. So ham, ABPA panel positive and fungal positive ball. It confirms your diagnosis of ABPA, and this is ABPA ham. So this patient was going to be started on chemotherapy. Now adding steroids in such situation will complicate the immunosuppression further. So we deferred for the systemic steroids. We gave him only antifungals because he was not that symptomatic with inhaled corticosteroids. And what is our observation in last 5 years in Tata, that even chemotherapy has an anti-inflammatory effect. So these ABPA respond very well in combination of chemotherapy plus steroid medications or fungal medications. So look at the total IG trend over a period of 12 months. The IG is normalizing towards 1000. So this patient radiologic also responded very well. The chemotherapy, radiation and durvalumab responded very well. Lung cancer responded very well. And the left side you can see there is a vacuole now. The mucus plug was sucked out, patient coughed it out, and no further mucus impaction, and there is a leftover area of bronchiectasis in this situation. So this case of ABPA ham. The last case is a case of a lung collapse in a hypertensive, uncontrolled, diabetic, hypothyroid, elderly female. History of asthma, presence with acute breathlessness, left lung collapse. You receive a call, chest physio done, not responding, bilateral wheeze. This is a CT done for this patient further, and you can see there is a lot of mucus impaction in the left lobe. When you do a bronch in such situation, you see this white, thick, tenacious secretions. They are very difficult to remove even with suction. So we used a cryo, and cryo is commonly available with Apollo at present. So you can see the abrasion created in the airway. A lot of ulceration happened because of such kind of mucus impaction. This is the amount of mucus which came out, and this turned out to be an Aspergillus. So again, the immunological parameter positive with lung collapse and Aspergillus on a sputum or a lavage sample supports the diagnosis of ABPA. And this patient was immediately post-op, the lung opened up, and this patient was managed with voriconazole, considering the deranged, her bad diabetes control. So only voriconazole for 4 months. I'm not going to go into further details of types of ABPA and clinical classification, but when the patient worsens, you have to rule out whether there is an immunological worsening or X-ray worsening. If there is increased shadows on X-ray, more than 50%, your total IG is more than 20%, and you have a picture of a diagnosed case of ABPA or a newly diagnosed case of ABPA, that's an ABPA exacerbation, has to manage with high-dose steroids and antifungals. If the immunological markers are negative, then it is a primary disease which has exacerbated. Asthma has exacerbated, or your bronchiectasis has an infective exacerbation. Remission, we look at 2 months. At 2 months, look at the clinical symptoms, look at his radiological parameters, more than 50% reduction in the shadows, disappearing mucus plugs, and you have decline in your total IG. That will tell you that patient is in remission. Now you can taper the steroids further. The response to the therapy. Remission is, you look at 6 months of the therapy and then talk about remission. Treatment dependent means you try to stop the steroids and patient develops the same symptom, same radiology and total IG high. Over a period of, suppose 2 times this has happened in the history, after stopping steroid, patient has developed the worsening of the symptoms, it means patient is treatment dependent ABPA. A long-term antifungal, long-term steroid versus another alternative modality of treatment like biologics should be considered in that situation. And if you have an extensive shadow on the X-ray, like bronchiectasis or like fibrosis, then that's an end-stage disease, and you start wondering whether this patient requires other therapy in form of transplant and all. So summarize, this is a common scenario, complicates the commonest respiratory conditions like asthma. You have very good guidelines available now. It's an algorithmic approach, 4 things you have to test in your patient. Treatment is steroids and antifungals, but it has to be judiciously used when you are dealing with multiple comorbidity patients. And any trained clinician who is aware of these guidelines and has a high clinical suspicion will be able to diagnose. And I'm sure today onwards in your clinic you will suspect an ABP and an uncontrolled asthma or a bronchiectasis case. Early diagnosis, better control, prevent the complication, and can prevent an end-stage disease as well. So have a vigilant eye and diagnose ABPS if
if there is any difficulty, you can refer this patient to a specialist for further management. Thank you.
Thank you, Dr. Apoll, for a very comprehensive and textbook presentation on IBBA. Any questions from the audience? Is there a question?
Yeah.
Thank you.
Thank you.
Thank you, sir, for a wonderful session. I would like to call Jaya ma'am to give a token of appreciation to Pawan sir and Suvadeep sir as well. Now I would like to invite Dr. Bhumika ma'am to deliver the closing note. Ma'am, please.
I would like to extend my heartfelt gratitude to our regional CEO, Dr. Arunesh Punetha, our unit head, Dr. Kiran Shingote, our DMS, Dr. Ravi Shankar, for their unwavering support. A sincere thank you to CIPLA team for the generously sponsoring this session. My deepest appreciation to Dr. Jayalakshmi ma'am. The session would not have been possible without her guidance and encouragement. I would also like to thank all our esteemed speakers and chairperson for taking out time out of their busy schedules to enrich our CME with their presence. Special thanks to our dedicated marketing and videography team for their behind the scene efforts in making this a grand success. And last but not the least, I would like to thank our wonderful audience for being here and making this CME truly meaningful. Thank you so much. So there is tea and coffee outside.